are a great reflection of the effort that the speakers have put in for all of us. I know that it takes me at least a day and a half to draft one of these talks, and therefore, apart from showing that you've all been listening, it will also be a compliment to our speakers if you could come up with a question. We'll take short questions on each speaker's specialist subject when they have finished, and at the end there'll be, I would hope, more of a debate going across the board, particularly tonight, about consenting, because that's one aspect that Julian has promised he's going to raise. Now, the management has asked me to deal with some housekeeping. Feedback forms, as ever, that helps us try to make them as glowing as possible. Guest tweet, to tweet us on hashtag Skeleton Series 2017. Webinar guests invited to chat using the chat function, which apparently is located on the webinar portal. And we've got a team of IT technicians waiting to deal with those questions. And finally, I'm going to welcome our speakers. As I said, we're going to start with Michael Kurer. Michael is well known to those who need an answer in relation to shoulder problems. He's a consultant orthopedic and shoulder surgeon at the North Middlesex, and all his qualifications and skills are set out in detail on the accompanying form. I'm going to spare his blushes. I'm not going to read them out. I'm going to start this evening by asking Michael Kurer to talk to us about shoulder surgery.
Well, good evening. Good evening. It's a pleasure to be here. And I've got a little lecture set out. I should be talking for about 50 minutes, 50 minutes. But if you all nod off in the middle, I'll realize I've got to hurry up and make it quicker. This is my overview, and I've got an overview for you here. And if it's a blue slide, that means we've come to the end of a section. And there's only 5 sections. So when you get to the 5th one, you know we're almost there. Okay, and this is the overview. What's the point of the shoulder? How does it do it? How does it get damaged? How do the doctors come along and try and sort that out? And finally, where does that bit go wrong, which is where you all come to your work. A pink slide will be about a subject which is relevant, I think, to all of orthopedics, not just shoulders, because obviously some of you have never seen a shoulder or have anything dealings with a shoulder. But there are points, I think, which are relevant, because in the past I've done lectures for all sorts of things and trauma things. So I think I'm aware of things that are relevant to other aspects of orthopedic clinical work. So pink slides means I think it's relevant to other things. So you wake up if you... Okay, before I start, though, I should just like to ask, when you saw this lecture and it said shoulder, some of you may have had some thoughts. I'm just wondering if any of you have some hopes of things I'm going to cover. So I'll just give it a second. By all means, stick a hand up and say, I want you to cover, phenylketonuria in the shoulder. And I'll think, oh, okay, because I'll just rewrite it quietly while we're... But please, if you, could I just ask? Yes. Right, so the question being asked here is frozen shoulder. If you'd like, hoping I'm going to address frozen shoulder. Wonderful, I will try and address that for you. Any other things that people were thinking, gosh, I hope he talks about? I've never really understood. Oh.
Posterior shoulder dislocation.
Posterior shoulder dislocation. Gosh. Golly. Okay, I'll try and cover. Oh. Yes? I'm only kidding, that's in here. It's in. Anything else people can think of at all? Good. Well, I have guessed what you should be knowing. So I'm going to tell you what I think you ought to know, if you like, in as straightforward a way as I can. But first, let us talk about whether this is worthwhile being here. And I think it is, because this has been analysed in the Bone and Joint Journal, British Journal, in 2014, looking at orthopedic stuff. And here's the breakdown of different parts of orthopedics and the litigation that goes with it. Shoulders and elbows, shoulders is more than elbows, 5% shoulders, 2.8% elbows. And here's the best bit. 18 million quid was paid out between 1995 and 2012. So there's stuff around, okay? That's just shoulders. So let's go to the first point. Here's first section 1. What is the shoulder for? And this is what the shoulder's for. Activities of daily living, which of course you all know about when you put your particulars of claim down. You know, what all the losses, activities of daily living, work and hobbies. That's it, isn't it? That's what it's about. And how does it do that? And that's it. That's the answer. That's what a shoulder's for. Because actually, the hand is what's everything. But the hand here is no use. And it's put in space to do things by the shoulder. Okay? That's all. I've finished now. Now we have to talk about the movements of the shoulder because people will talk about this is jargon, this is stuff. And the movements of the shoulder in order of importance. The most important movement of the shoulder is flexion, which you can see here on that side over there. There's flexion. And it's basically bringing your arm forward. That is the most important thing in life. You want your hand in front of you. You want to say hello to somebody. You want to reach for something. You want to push something, pull something. Flexion. Most important range of movements. Flexion, it's measured all the way up to here. 180 degrees is here. This is 90. We're very straightforward people. The next most important range of movement, is internal rotation, which is reaching around behind your back so that you can toilet and scratch your back, tuck in your shirt, pull your wallet out of your back pockets to pay for a round of drinks, if that's what you're minded to do. Okay, so internal rotation. And again, that's measured how high you can get up your back. So you place your thumb in the middle of it, and these are vertebrae top to bottom, and you hear them say, you hear us talk about them touching the T6 vertebra, or the T7, or the L1 vertebra. Some other movements. External rotation. It's a tricky rotation, tricky movement to explain. It's like the arm opening like a door, like that. It's not that, it's like that. It's this door movement, if you like. That's when you put your arm into a sleeve of a jacket. It's quite useful. External rotation. And then finally, abduction, which we don't really do very much. It's not a very important movement. That's why it's last on this list. And you might use that to, when you're driving out of a car park and you want to put money, the credit card in the machine. But it's not we don't do this very much because really, if we want to, we can just do this. Okay, then there's the other aspect of shoulder work, which is bimanual activities. And that's where both arms work together. And there's stuff like that around the home, and also we'll come on to that shortly. But bimanual activities, and here are good examples of bimanual activities where both have to work together. So an electrician with a bad shoulder can't be an electrician. You can't do that. So let's just talk about the activities of daily living you all know about that are relevant to the shoulder. And here they are. All of these, you need a bit of a shoulder. And if your shoulder hurts or is restricted, you will have difficulties with those. And things will take you longer, or you may need assistance with care from other people. Okay? I know you can all read, so I don't have to read it out for you. And then one thing that people forget about a shoulder is that it's a very important device for sleeping. And I have any number of patients come to see me and say, look, the problem I've got, I can manage during the day, but please get me a good night's sleep because I cannot sleep on my shoulder. It hurts too much. And in fact, when I'm not on my shoulder, it hurts at night. For some reason, we don't really know, shoulders hurt a lot at night. So night pain, very important. They get sleep deprived, miserable, depressed, etc. So it's a big problem with patients, night pain. And you can see, obviously, why. So now we come to the activities of daily living. So you got up in the morning. I would say, how long is it? When was the first time you could get out of bed, go to the shower, have a wash, put on your clothes, and come down for breakfast? And they'll say, oh, it's about 7 weeks. And so all that time, that 7 weeks, they've had to have care and hours of help from their partner or all the rest of it. So once they're down, once they've got themselves independent, what are they doing around the home? This is all, again, stuff which the shoulder is relevant to. All this stuff, again, hanging out, washing, and people don't put them in tumble dryers. But all these things, you need a shoulder. Some are lighter activities, some are elbow greasy types, but all of these are relevant to a claim for a shoulder problem. And again, the bimanual activities, reaching a tray from an oven, putting things up, putting suitcase. And then the other domestic aspects which you know about, which are sort of semi-optional, the DIY stuff. Obviously, you can't go and paint and decorate if you've got a bad shoulder. And people say, oh yeah, but why can't I paint? And the answer I would give to that is, if you're standing on a ladder, you've got to climb a ladder. You've got to steady with one arm while you paint with the other. So even if it's your right arm, your dominant arm, which is fine, and your non-dominant arm is not, they can say, well, I can't do it. And you certainly can't, use a brush and wallpapering. You need both arms. So DIY and home improvement, obviously, putting up shelves, all that sort of stuff. You need shoulders. And then gardening, laying patterns, the heavy laying stuff, and mowing lawns, all this sort of, all the shoulder relevant stuff. And then I put in children because one often forgets this. These days one cares for children and one for grandchildren, looking after all this, again, to pick children up and do things with them, to be safe with a child so that the mother can go off to work or a relative can go off to work. You have to have two good shoulders. You can't look after a child with one arm. It's not going to work. And now the work aspects of these, again, the sort of work jobs that you need a good shoulder for. Obviously, overhead activity, that goes without saying. I mentioned the electrician already, I mentioned the bricklayers, all this sort of stuff. Plastering, I mean, there's nothing worse than plastering for a shoulder problem. I mean, you just cannot be a plasterer with a shoulder. There's Hawk business with the place, and then they're doing all this sort of stuff. I mean, it's not going to happen. Out of the question. And then other things, the car mechanic, he'll have power through his arm, even if it's not necessarily up here. Anything with a lot of power, even at this level, power, you need a shoulder. And then the repetitive activities. You can't be a supermarket checkout person with a bad shoulder. You just can't. It's too much repetitive activity. Driving the same. You can't really be a minicab driver if you're shoulder. You can if you really want to go and get a modified, car driving thing. But it's a performance. And again, if you're a taxi driver, you're supposed to lift people's suitcases. Your tips go down. And then computer mouse. Now, again, that must seem obvious, but actually, using a computer mouse, the mouse hangs off your shoulder. I know you think I'm some sad person now, because every sentence has the word shoulder in it, doesn't it? But it does. If you're doing this all day, it's all hanging off your shoulder. You can get a way around that is to get a wrist support and do it this way. But again, people doing a lot of mouse work will have difficulties if they've got a shoulder disorder. So it matters. I think I've demonstrated that it matters. And then, of course, hobbies. Let's talk about the hobbies, which are obviously to a certain extent optional, but to, give people a sense of who they are and enjoy them and are a release. And these are the hobbies, for example, where, again, if you have a shoulder problem, you're not going to be able to do them properly. Swimming is crucial, obviously, and it's the overhead sports, but strokes, front crawl, back crawl, butterfly. With a bad shoulder, you're not going to do those. Racket sports, again, serving and smashing are not good. If it's a non-dominant arm, they're throwing up ball up a bit. They can get by, but it's not great. But then two-handed backhand or something like that, again, they're going to complain if it's the non-dominant shoulder. Golf, gymnasium and aerobics, that's, again, need shoulders for all that. And people don't feel like going if they can't do half the exercises. Dancing's another one. It's amazing how a lot of people dance all evening and won't do it. And then the orthopedic, the shoulder surgeon's friend, rugby, which is designed to create disorders for us. And that, again, you're not going to do that if you have a bad shoulder. So on to section 2. And section 2 really is so we understand what the shoulder's for. We understand now how everybody uses it. Now we have to try and work out how the good Lord has made this happen. So we start at the basics, and the shoulder is a ball and socket joint. The picture over that side, the far side, this side over here, so it's the left as you're looking, shows the humeral head, the ball, which is actually a hemisphere. It's half a ball. And the socket, and you can see the socket, it's a vertical plate. It's not like an egg in an egg cup. An egg in an egg cup is very, very stable. Hip joint, for example, again, the same thing, very, very stable. Not many people come to you, so they'll have a terrible business, I've got my dislocating hip. That's not what happens. Whereas people dislocate their shoulders, and they dislocate their shoulders, you can see why, because the ball slides off the plate. It's not very well constrained. The reason it's not why the good Lord has decided to give us that is that it gives us an enormous range of movement. This doesn't happen to a hip. A hip can't do all this. But the downside is that it's unstable, that if you traumatize it in a bad way, it slips out. So that's fine. The question, now there's another part of the hip, of the shoulder you'll hear about, and that's this thing here called the labrum. And that's just a rubber skirt that goes around the edge of the plate, making the plate a bit deeper to add a little bit more depth and stability to the shoulder, to the socket side, to give a little bit more stability. And here is the socket end on. You can see it's pear-shaped. It's only little, and you can see this labrum, which just makes it a bit deeper. So there we are. We've got a ball which is very nice. It moves in lots of directions. We've got a socket which basically holds it in place, but obviously it's terribly unstable. How are we going to stop it from falling out? And we stop it from falling out with this capsule or sac. And the way to think of the capsule or sac is like a hammock. It's just lifting and holding the ball in the socket. It goes higher than both sides, but it's basically a sac, a hammock, which holds the ball tight in the socket. But it's loose enough to allow it to move in all these different directions. It's inert. It just sits there. It's like a set of strap. It's just plasticky. It's not got any. It's just a sheet. So there's that. But that's not enough. That wouldn't be enough. It's not that. And now there's this thing that a lot of people have heard of. You know, you see it in cartoons. Could be your rotator cuff, but no one really knows what it is. And I hope now to explain to you what the rotator cuff is, and I hope you have some sense of what the rotator cuff is. And what it is some muscle around the humeral head and the sac. So we're looking at on the left-hand side, we're looking at the front of a right shoulder, and there's muscle along the front. And at the back, on the right-hand side of the picture, there's muscle along the back. And there's a bit at the top, this supraspinatus part is on the top. So you've got it on the front, the top, and the back. And it grips the ball and holds it in the socket. It holds it there all the time like that. It's a muscle that pulls it there, holds it in the socket. So it keeps it centered for you. In fact, it's even clever than that. Not only does it just hold it centered, but it holds it centered all the time. And in fact, it powers the ball as well and holding it in the socket. It's really quite clever. So not only is it centered, it actually powers it around like that. That's your rotator cuff pulling it, as well as holding it centered. Okay, so three main bits: infraspinatus, supraspinatus, subscapularis. They're there. It's basically holding it in the socket, and it's outside the. So just so you know, the sac is underneath, and then on the top of the sac is this rotator cuff business. This muscle. It's a muscle, and like many muscles, it has a muscle belly, which is the red bit, and then a tendon, a strap, which is what's used to attach it to the bone. So there's this rotator cuff. Okay. Then there's one other muscle which I've got to mention for completeness, but never gives any trouble, and that's deltoid. And that's a second muscle which gives you the shape of your shoulder and which you'll have your childhood injections into, and it's deltoid. And that works together with the rotator cuff. They work together. So this pulls, the rotator cuff pulls the two in tandem all the time. It gives you this very, very powerful unit, which is stable. Okay, and this is a sort of diagrammatic representation of how the two work together. The rotator cuff is on the bottom here, like somebody holding the ball in the socket and pulling at the same, and then the deltoid is like this man pushing on the humeral shaft over here. So two muscles working together, one pulling on the ball and one pushing on the shaft, and together the ball stays centered right there on the socket and moves in all these different clever directions. Now, I mentioned two other muscles which are of which are of litigation relevance. So you need to know about them. One of them is biceps. You all know about biceps. It's, you know, all know about biceps. But biceps sits here. But biceps is attached at the top, in fact, to the shoulder blade, and at the bottom to the radius down here past the elbow. And biceps, like many muscles, will rupture. It snaps. It snaps at the top, and if it snaps at the top, there's no litigation about that. But it also snaps at the bottom, and people miss it. So people will lift something and they hear a snapping noise. They go to the GP and says, oh yes, you've got a bit of spraining of your biceps, a sprained bicep. It's not, it's actually off. It's come away. Distal biceps rupture. Distal biceps rupture is for litigation. Proximal biceps rupture We don't do anything about those. It's a cosmetic problem. They don't get functional loss. I won't go into why, but they don't. Then there's the pectoral muscle. Again, one you wouldn't necessarily think about. These pecs, you know, you're in the gym, you know, all this. This is pectoralis major. And this too gets ruptured, and this too is not noticed because it's quite rare. And the typical history of somebody at the gym bench pressing, feeling a tearing sensation, oh, a tearing sensation. They're often quite well muscled, so they're quite muscly anyway. They get some swelling. They go to the hospital goes, yeah, you've sprained it, something, rotator cuff, you know, and it's not. It's a pec major rupture. Like muscles recoil. If you don't get them back within a month, 2 months at the most, they become irreparable. So it's a very straightforward no-brainer. Right, let's talk about some other bits about the shoulder which can, you know, are relevant, I'm afraid, to what you do. And these are the nerves around the shoulders. The brachial plexus. What is this brachial plexus business? The brachial plexus is a collection of nerves just in front of the shoulder. Nerves come out of the neck, you know that. They come out one nerve from every level, but they coalesce into this group of nerves here called the brachial plexus. It's just a collection of nerves. There's no more to it than that. But it collects but the nerves, they collect together and they're just around this artery here, the axillary artery. So they collect up into a group and then they spread out into the lower arm. And they're useful here because anaesthetists can put some local anaesthetic around them and switch off the arm. And that means you can have surgery on your arm without having to be asleep. That's called a brachial plexus block. So people do that, and shoulder surgery as well, switch off the brachial plexus. And even if the patient goes to sleep, they need only a very light anaesthetic because the arm's asleep. They hardly need anything to keep them down, as it were. And that's what anaesthetics do, they keep them down. So the brachial plexus round here, important, very important medico-legally. The axillary artery and vein, important medico-legally. And then there's another nerve, which I'm going to talk about, which is near the shoulder, and that's the accessory nerve. And here's the accessory nerve. And notice this is a pink slide because this is ENT, for general surgery, all sorts of stuff. The accessory nerve. And it's a cranial nerve. It comes out of the skull, comes down here, and it supplies the trapezius muscle, which is this muscle here that you use to, you know, rid of this muscle here, and some other stuff too. And the problem is that in this area here, you get, in this area called the posterior triangle of the neck. It's called the posterior triangle because there's one part of the triangle, there's the second part of the triangle, there's the third part of the triangle, posterior triangle of the neck. You have lymph nodes. And when people that maybe have Hodgkin's lymphoma or they've got some illness and not really sure, and there's a lymph node palpable, they say, oh, we'll biopsy your lymph node. Unfortunately, they also biopsy the accessory nerve. And that's not picked up. But even if it is picked up, they're very difficult to repair and recover. They can be repaired, and in the literature it says, you know, they do fine. But it's black and white negligence. You may not cut the accessory nerve. And it's a whole performance to sort things out. And this is what they come along with later, this accessory nerve palsy. This is exactly what they're like. And they're just weak and unhappy and achy. And I've had one of these. They settle for sort of 100,000, that sort of. There's always a lot of stuff to go into, you know, it's proper. It's not a $5,000 job, not at all. So now we go back to more of the shoulder. You know the collarbones, the clavicles, there they are. And the collarbone meets the shoulder at this little joint here called the acromioclavicular joint. I'm sorry about that, that's what it's called. It's called the ACJ for short, and that's, again, relevant to what we do. It's part of this, it's near the shoulder. It's the edge, the outer end here. There's the acromion, I'm afraid. Here's the clavicle, acromioclavicular joint, some ligaments to hold it in place. It's just there. And one of the things the collarbone does is it protects you from being someone whacking your brachial plexus or your arches because it runs across that. Okay, next section. Section 3, we're doing all right. Things are going all right. How is the shoulder damaged? In other words, why do people come to me with a shoulder problem? That's what this is about. And you can break it up into two things mainly, trauma and aging. Then there's a few diseases which attack the shoulder, rheumatoid arthritis, another disease called avascular necrosis, which you'd have heard of for the hips and things. But fundamentally, it's trauma and aging are where we're at here. Now, before we go on, I'm going to talk about fracture healing, and notice it's a pink slide. It's a pink slide because fracture healing is fracture healing. And there are three different bits about fracture healing. When two bones break, they start to heal. And they start to heal that second, and that's called the process of union. And it usually takes about 6 weeks. For some bones like the tibia, it can take 12 weeks, but it's an ongoing process where new bone is formed and the bones fractures glue together and unite, hence the term union. Sometimes it doesn't go so well. It goes slowly. So the patient's healing. You look at the x-rays, you can see something going on, but it's not healed, it should have healed, but it hasn't healed. But on the other hand, it's healing. So we call that delayed union. We say we think this patient has delayed union. If we wait a bit longer, he will then unite, by definition. Sometimes the whole process switches off altogether, for whatever reason. 2, 3 months down the line, 6 months, whatever, year down the line, nothing's happening. The bones are still sitting there like that. That's a non-union. Okay, that sounds always straightforward, doesn't it? So let's go on. A potent source of litigation is the failure to diagnose non-union. Because what happens is the patient comes along to the fracture clinic, sees the consultant says, oh yes, this is coming on, we'll see you in 6 weeks, take an x-ray, you should have united by then. Patient comes back at 6 weeks to a check x-ray, and when you x-ray a bone, you can see healing progressing. And if we have a look at these pictures here, this is an x-ray of a tibia and a fibula. 3 sets of them, a tibia and a fibula. And a surgeon has come along and he's put a steel nail down the tibia, an intramedullary nail. Okay, so we can see that. You can see this size A. Here's the break. There's the nail. The fibula is also broken. We can leave that to sort itself out. But the tibia is what bothers us a lot, so we put a nail down to stabilize it. And on the next x-ray, B, you can see there's a difference between the bone shape around the break here and here. You can see it's changed. This is filling out. You can still see the line of the break a little bit. You can see there's action happening here. It's as if the body's sending in bone glue, which we call callus. In it goes, gluing this up, making it nice, and thinking, aha, this is good, this is healing. And also at the same time, the patient will be saying, yes, no, it doesn't feel so sore, actually. It's quite good. And then we bring back later, another, say at 12 weeks or 16 weeks, and sure enough, you can see it's now smoothed off altogether. You can't see the break, the line, the fracture anymore. That's union. It's united. Okay? That's good. Meanwhile, if we look at the fibula, that's like that at the beginning. That's still like that at 8, whatever it is, weeks. That's still like that at the end. That's not united. That's a non-union. That's just sat there saying, you know what, forget about it. I am not uniting. Goodbye. Okay? So the question is, at what point could we say for sure that this wasn't uniting? And the answer, the simple answer is, you need to see improving callus on consecutive x-rays. And those x-rays should be 6 weeks apart. And the hard bit is, I say, well, the penetration is different, the angulation is different, all this. And what happens is the consultant sees them the first time, the registrar sees them the second time, the registrar sees them the third time, a new registrar or SHO sees them the fourth time. And they're all going, well, I'm not sure. I think it's a delayed union. I think I can see some callus. I'm hoping it's some callus. So, see you in 6 weeks. And before you know it, a year's gone by. The patient's still limping in. Or in case of the humerus, they're getting this. Or in case of the collarbone fracture, it's just not healing. So this is, to me, a potent source, a rich source of work, because they just haven't come off the fence and said, this is a non-union. Okay? Treatment for non-union, this is the same. All fractures, you operate. And you don't put them on the end of your routine list. You tend to bring them in within 4 weeks. And you bone graft them usually. You fix them with a plate and screws or some device, and graft, and they unite. Okay, so here we go to the broken bits of shoulders. Obviously the collarbone, and the collarbone is divided into the middle, not surprisingly, which is, sorry, I pressed the wrong button, which is the middle, which is this, but the middle of the collarbone. It's a classical standard place the collarbone is broken, the middle, mid-shaft, and then the outer end, which is the lower picture, you can see it's the outer end of the clavicle. So by and large, the standard treatment for these is to stick them in a sling, and then they heal at about 6 weeks, 12 weeks at the most. If they're not healed by 12 weeks, it's a non-union. The lateral end of the clavicle fractures tend not to unite, whereas the mid-shafts tend to unite. There's no absolute indication, by and large, for operating on these. So again, a reason, I get a lot of questions. Here's this patient, they've managed with their thing, then they finally at 12 weeks went to see an orthopedic and said, well, I would have operated on this straight away, and it's outrageous. And, oh God, should he have operated? No, there's a significant proportion of orthopedic surgeons who do not operate on these straight away. So that's not a goer. The lateral interclavicles are prone to non-union, so they need to be watched, and if at 12, 6, even 12 weeks they've not healed, you have to operate on them. Okay. ACJ dislocation, this is a fall on the point of the shoulder. Cyclists will get this a lot, and again now we've got a plague of cyclists because of this. I mean, it's a marvellous thing, Boris, by all this, so great. People will live longer provided they don't get knocked off. So ACJ dislocation, here it is, you can see these things are, and this flies up. Again, I'm often asked about these. Treatment for this is conservative, and that's because it turns out that if you leave them like that, and you can see the shape of them changes, you can see this is their normal side, this is their abnormal side, it doesn't look good in the mirror, they're not happy bunnies. Nevertheless, 80% of people at 12 weeks will come back and see you and say, I'm fine actually. I know I've got a bump. I know it's, but actually I can do everything. I'm back on my bike, I'm back at the gym, I don't care about the appearance, and goodbye. 80%. 20% will turn around and say, no, this is no good. And then we fix them. We do a late fixation. So the initial management of these, again, is not a goer, because these injuries are missed. They go to A&E, oh, it's a sprain, and then 4 weeks later, no, it's an ACJ dislocation. Oh, you should have operated. No, we wait 3 months. Proximal humeral fracture, people fall and break their shoulders. It's a fragility fracture or a high energy fracture. And I only mention this business about parts because when you read about shoulder fractures, you'll hear it says so many parts. Obviously, if you break something in two, that has 2 parts. That's a 2-part fracture. Then there's bits of other bits can flake off as well. Here's one, here's another. So this would be a 1, 2, 3, 4-part fracture. I'm just mentioning it because they're all just fractures. Okay? They often have surgery. We use plates and nails. It takes them 6 months to recover. You can say straight away, you've got 6 months of hell ahead of you. Now, this is hot off the press and absolutely infuriating for surgeons who think we do think we're very clever. We really do. And let me show you, I'll show you this next slide. Look at this. This is what we can do to broken shoulders. We can put a very clever plate and screws in it, or we can put a very clever nail in it, and it's marvelous. And in the patient comes, I'm going to operate, I'm going to fix you, I'm going to get X-ray, that's fantastic. Only problem is this study that has just come out, Pearse study, proximal fracture of the humerus evaluation randomization trial, where 22 centers in the United Kingdom randomized officially. Half the patients were going to have surgery, and the same half flipped the coin, were not having surgery. And then they were evaluated at 2 years, just the same. Just the same. How infuriating is that? So obviously all the soldiers are up in arms about it, saying, no, you haven't randomized them properly. And unfortunately, the study hasn't been done absolutely properly. Nevertheless, as a litigation lawyer, somebody comes along and says, I should have had an operation, I didn't have an operation, all they go is, Prof, end of the case. So I warn you about it. So those are what we do to things. Plates and screws. This is a pink slide because all fractures are treated with plates and screws, and all fractures are treated with because the bone is tubular, we can drop a nail down the middle which splinter it, and we can stop it twisting on the nail by putting screws in between called interlocking screws. So when do we operate? And again, this pink slide, because this applies to all fracture surgery. When do you operate? And the simple answer is, if you look at it and you know the future, and you know that if you leave it like that, it's going to be dreadful. And they say, look, this is dreadful. So you can see this one here. Here's a fracture. Here you can see there's a little proximal fracture here and here and here, and this isn't great. You think, well, that's not going to do well. I need to put that back to here, and then it'll do better. So we know that. So any of these sorts of things, I'll show you others in a minute. So if you know that it's lousy, then you must operate. You must operate. You must tell the patient, unless we operate, you're going to get a lousy outcome. It's your choice. You may not want to have an operation, it's fine. But my recommendation is we operate because the outcome will be better if we operate, which was what we used to say before the damn Kurer trial came out. Secondly, if the fracture moves, so you've got the fracture, it's in plaster, everything's fine, but unfortunately on an X-ray a week later, it's shifted. And you, right, now I can see in the future it's going to be no good, so now we have to operate. Fails to heal, we've talked about non-union. And then the other thing about which I'm sure we're going to come on to, which is if the patient wants an operation. If the patient, when you balance them up and say, look, I'm going to give you a 9 out of 10 shoulder if I operate, you're going to have a 6 out of 10 shoulder if we don't operate, what do you want? And he goes, you know what, I'm 75, I used to play golf, I don't anymore, I used to this, I don't anymore. I'll take my chances, I'll take the 6 out of 10 shoulder. Besides, I've read the Proffer trial. And I know I'm going to get 8 and you can't get me better than 8 anyway. Okay, so it now becomes very important. What exactly are you doing for me, doc? So here's another one. You can see this is we now go down. That was the proximal humerus up at the top, snapping the toffee apple off the stick, if you like. Now we go down to the mid shaft of the humerus, and here you can see an angulated fracture. Same thing. These tend to be managed conservatively with a brace. I think I've got a picture of a brace somewhere. Thought I had. No. They get managed conservatively with a brace as a sort of Velcro thing. Plates and nails we've mentioned, and now we've got to talk about. Here's a plate. And screws as we've seen. Here's a broken arm. You can see it all smashed up. Here's a nail going down it with screws, all very clever. There's no Proffer trial. You've got to do this. And then this is another important aspect of litigation. One of the nerves coming off the brachial plexus is this nerve called the radial nerve, which comes down here, round the back of the arm and down to here. Okay? And if you break your arm there, it can get stretched anyway, and the patient comes in with a broken arm like that. And secondly, when you operate through the back, and you see we're operating at the back of the arm here, here's the hand, we'll go down the back here. The radial nerve is always nearby. Here it is. It's always nearby. So we want to put a plate and screws here, and I have, it's clearly easy. The thing about negligence work is, you know, these other people are good chaps. So if they've done it, it must be easy to do. And I've got 3 or 4 where somehow or other, the surgeon has crunched the plate down on the radial nerve. You know, having found it, having seen it, nevertheless, patient wakes up like that, and 4 months later or 3 months later, they go to the Royal National Orthopedic Hospital, take out the plate, and there's the nerve sitting underneath it. Completely indefensible, obviously. But this is a potent, you know, the radial nerve is here. Right, now, pink slide for nerve injury. I need to talk about nerve injury. It's a universal thing. There are 3 sorts of nerve injury. There's neuropraxia, which is just a little bit of stretching of the nerve which occurs as part of surgery, like cracking eggs to make a scrambled egg. You get some weakness, some numbness, but only for 6 to 8 weeks. And then there's a full recovery. Then there's this term axonotemesis, which is more than that, which is where the nerve's been given quite a stretch, but it's still intact. So the little tubules that you can see here are still there, but the nerve inside dies back and has to grow back down again. And in simple terms, and then there's neurotemesis, which is where you take the knife and cut it in 2, or ruptured it so much it's just 2 bits flailing about. The medico-legal stuff is about the axonotemesis, really, because neurotemesis is indefensible unless it's planned. Now, if you've got a tumor, and sorry, the tumor is going through your radial nerve, we're going to have to sacrifice the radial nerve. Okay, but by and large, nerves don't get cut. Obviously, the plate under the plate under the on that's crushing the nerve, that's a neurotemesis. It's finished. Nothing to talk about. Let's talk quantum. Axonotemesis is the more tricky one, where the patient comes back and says, well, it's a bit weak, it's a bit numb, it's a bit painful, it's a bit achy, and they get a sort of partial recovery by 9 months. That's an axonotemesis. As far as I'm concerned, by and large, that's a breach. So not getting better by 2 or 3. There's some mitigation, but by and large, axonotemesis is a breach. Right, now we come to dislocation surgery. To dislocation, and shoulders dislocate. And they dislocate anteriorly, frontwards, and that's the picture here. And you can see that. If you look at that, you can see that don't look good, does it? That ball is not in that socket there, okay? And then they dislocate backwards, posterior. They do. And they dislocate backwards with funny falls, again off bikes, officially with electrocution and fits. They dislocate backwards. And this is this is backwardly dislocated, and this is not dislocated. Backwardly dislocated, not dislocated. Now, I can understand you going, hang on a minute, I can't really see much difference, to be honest. I know you're telling me there's a difference, and I can stare at it and go, meh. And the truth is there isn't much difference. There is a difference, I promise you there is a difference, but there's not much difference. And so these are missed, and it's a negligence, it's black and white. They then get secondary osteoarthritis and the whole big performance. So posterior dislocations missed. It's always a breach. You're not allowed to miss it, even though it's hard luck. Then there's rotator cuffs. And rotator cuffs get torn. And here it is, this business. Oh, sorry, press the wrong button. Here's a rotator cuff. There's a tear here, and they get torn. These are a bit of a minefield, I'm afraid, negligence-wise, because lots of people are falling and getting little tears in their rotator cuffs, and you don't do anything. You wait, and then they do very well, even though they've got a torn rotator cuff. So fixing them so missing them and operating on them, it's all a bit of a minefield. Fundamentally, you've got 3 months to fix them. Certainly 3 months and perhaps longer. But you need to get onto them, particularly with young people and particularly, say, under 60, particularly with a very good history of trauma. You know, they've fallen off a motorbike, they've fallen down the stairs, they had a terrible wrenching injury, and then they're like this, for several weeks. So it's a bit of a minefield, but then there's this thing called impingement, which is which is the commonest shoulder disorder. We go to a cocktail party, we talk about shoulders, someone says, oh, I've got this achy pain when I reach up. This is not negligence. This is just because some of you have shoulder pain and you wanted to know, and I'm here, so I'll tell you. Just when you reach up like that, this achy pain is when this tendon here, this supraspinatus tendon, just this one here, starts to rub on the undersurface of that, and you get pain. And it's treated with cortisone injections, physiotherapy, and if necessary, with a thing called an acromioplasty, where you file some bone off here to make more space for the tendon to go in underneath. These days, of course, we do it keyhole, but I'm just showing you this as an open one so it's clear. We also excise the acromioclavicular joint because you don't need an acromioclavicular joint. And just to be clear, you need to take out enough of the acromioclavicular. You mustn't leave bits behind. That's another, I've seen those too. Right, let's move on. Chronic, yes, I don't want to talk to you about this. Yes. Yeah, rotator cuff repairs, this is the other thing to say. Rotator cuff repairs often fail. So just because you had a rotator cuff repair and just because it didn't go well and just because it failed doesn't mean it was negligent. However, it's got to be done properly. So it's no good saying, oh, we only had one anchor available, we only had this, we couldn't do that. They have to be immobilized properly for 6 weeks, and then they have to have very gentle physio. And I have cases where basically the physio didn't know what they were doing, brought me, like this the next day, come on, no, you can do that. No, you can't, you've just ripped my rotator cuff repair. This is what a rotator cuff repair looks like diagrammatically. You can see here's the tear, this is the tear, we put some stitches and we pull it back to here. We pull it back through the bone like that. And these days we use little anchors, which are they're about the size of a grain of rice. They're not very big, 2 grains of rice. They're quite small, and they have stitches attached to them. And we sew this down, and that gets done as a keyhole procedure. And it's difficult, and we're all slowly getting better at it. But again, it's another possible source of work. Talk about dislocation surgery. You remember me talking about that labrum business, that thing that makes the socket bigger. If you're playing rugby and someone wrenches your shoulder, you tear the labrum and you stretch this, the capsule, the hammock. And these days we repair that by sewing this back, that back, that back, like that. It's done arthroscopic, it's done open, it's a good operation, usually successful. And you have to do it by a specific technique. If you don't do it properly, then there's a problem. Now, arthritis of the shoulder is not a common problem. I'm telling you, I know it's a bland thing to say, but I'm just telling you, I promise you, knee arthritis, hip arthritis, neck arthritis, back arthritis, common as muck. Shoulder arthritis, probably genetic, not very common. It happens. Rheumatoid arthritis is much more common, but these days rheumatoid is being zipped in the bud by the so-called anti-TNF drugs, so we don't see so much rheumatoid arthritis of the shoulder. Arthritis of the shoulder does happen. Here's a normal shoulder, and here's an arthritic shoulder. You can see here's the bearing surface supposed to have a gap in it, nice smooth round ball. Here we're getting a bit more of a square ball with these extra little bony horns on the side. That's what an arthritic shoulder looks like. And the treatment for this is shoulder replacement. Obviously it's cortisone injections, physio and all that, but when it doesn't work, shoulder replacement. And this is important. Here's a shoulder, And this is the shoulder replacement. And you can see what you do is you replace the ball with a bit of metal and you replace the socket with a bit of plastic. And it's supposed to be the same shape as this was before. That's the deal. I came in with this, I was born with that, now give me one like that that's the same as the one I was born with. That's what the surgeon's contracting to do. And please note this is a pink slide because that applies to knee replacement, that applies to hip replacement, everything else. The deal is you are going to give me the right shape. You are going to give me the right length, the right height, the right everything compared with what I used to have. And that's the deal. No surgeon goes, no, actually I like putting over long ones, or I like putting short ones, or small ones, or big, extra big ones. That's the deal of all joint replacement. And there are recognized techniques, as the manual tells you how to do it, and you adhere to the things, and if you can't do it, you don't do it. If you can do it, you have to do it that way. And if you do it wrong, you get sued. Okay, then there's this thing called a massive rotator cuff rupture. I'll just go to very quickly where the muscle tears and the ball rides up. You see how it's ridden up here and it's gouging away on the undersurface of the clavicle, and that hurts. And these days, we do a thing called a reversed total shoulder replacement. How mad is that? What we do, and I'm only saying this because you're going to see something about reversed total shoulder. What you're going to see is we make the socket into a ball and the ball into a socket. That's called a reversed total shoulder. Surprise, surprise, it's called a reversed total shoulder. And that helps, and people can then do this. I explain why, don't you explain why, but that's here. And you're going to see loads of reversed because they're now you salvage for anything you like. Broken shoulder, bad reversed. Infected shoulder, reversed. Everything's reversed, okay? Let's just quickly talk about this. Another red slide because it applies to all infections of implants. If you get an infected implant, there is a recognized way of treating it, and that is that you have to take them back to theatre and wash them out. You have to change things that are easy to change, like plastic inserts. You have to give them IV antibiotics at least for 2 weeks, probably for 6, and you have to follow the ESR and the CRP and all that sort of thing. And by and large, if you can take a fresh joint replacement back to theatre within 2, the maximum 4 weeks, you can usually salvage it. Whereas if the GP, God forbid, sits on it and goes, oh no, I think it'll be all right, have some more penicillin tablets, and 6, 8 weeks down the line, they come back with a pussy hip, shoulder, doesn't matter, then that's zapped and you have a claim. Finally, into the home straight, I'll just have a quick sip of water, into the home straight, where does it all go wrong? So these are a few examples which are easy for me to show you, black and white stuff. Fundamentally, as a doctor, this is what we're supposed to do. And it seems odd, but it's important to document, because if you fail in any of that, then it's a breach. So you're supposed to take a history. You're supposed to examine the patient. This is one where they fall down. You're supposed to think, I'm not sure what this is, but there's 4 or 5 things it could be. Very important. Then it's a duty to form a differential diagnosis. Then you do your investigations, other tests you like, to exclude as many of those as possible. Then you have your thing called your working diagnosis, which might still be 2 and you're still not sure, in which case you start again. You take a history again. You examine the patient again. You do your differential diagnosis again until you get the absolute diagnosis, or you all give up, say none of us know, or you go to call another doctor, all of the other things. But that's the process. That's the clinical process in looking after patients. And if you fail, particularly with a differential diagnosis one, you say, I know what this is. I had one recently. Terrible, terrible. This fellow said, I know what you've got, he said to this patient. You've got shingles of the shoulder, he said. You've got shingles. He didn't. He had he had necrotizing fasciitis, and he died. Yeah. He didn't have medicines for 48 hours. He didn't have any IV medicine, no antibiotics. He was given a bit of anti-shingles medicine. It's a disaster. And it's indefensible. The coroner said it was indefensible, so it wasn't a difficult case. But of course, what did the defense say? Oh, he was going to die anyway. Prove to me he wasn't. Difficult case. Okay, so that's that. So next one, failure of diagnosis. Posterior dislocation we've mentioned. This is next thing, failure of diagnosis. Anterior dislocation in obese, they miss. These are things that are missed. ACJ dislocation, I've told you there's no causation. Fractures around the shoulder can be missed, and that's very painful and unpleasant for the patients, and they can then go to non-union. Rotator cuff rupture, I've mentioned before, can be missed. They think it's just a sprain, but it's not. It's actually in 2 bits. Biceps rupture distal, we've mentioned again, they think it's a sprain, but it's actually off. Pectoralis major rupture, off, but just a sprain. Tumours and pathological fractures is another one that can be missed, where somebody has a relatively trivial fall, and they fall and they break their arm, and actually they've missed the fact that it was a secondary tumour in there, or a primary tumour in there, which caused it to be so brittle. Failures of supervision. Now, failures of supervision, this is where our job is, what you've got the patient, you know he's got this, and now you've got to look after him until he gets better in a recognised fashion. So malunions are not allowed. You're not allowed to let a patient go with a malunion. You've seen him, he's straight to start with. You're not allowed to let it drift. And then the guy comes back and says, well, my wrist's no good, or whatever, or in the shoulder case, the thing falls into them and they can't lift up properly. Delayed diagnosis of non-union, I've mentioned, it's a tricky one, but it's there. Failure to address surgical errors is another one. You're allowed to, look, you're not allowed to leave a screw in that's long. You take the x-ray the next day and you think, oh God, the screw's too long. This happens. Okay. So the answer is, sir, I'm so sorry, the screw's too long. I'm taking you back to theatre, I'm going to put in the right size screw. And he's going to sue you. You say, all right, it's £5,000, finished. One operation, £5,000, nothing. They don't do that. They go, I tell you what, I'm gonna keep this quiet, and all being well, this will just go away. And then the screw gouges its way into bits and bobs and all sorts of stuff, and it all goes terribly, terribly bad, and then that settles for 100 or 200 or 400. Okay, so failure to address surgical errors is a thing that comes, I see. Failure to treat infected implant properly, I mentioned officially, you need to crack on. You must take the bull by the horns and go, look, this may not be right. Take it back to theatre, wash it out, IV antibiotics. We may not save it, but at least give them a time. Surgical errors is another bit. Damaged nerves, you're not allowed to cut nerves, stretch nerves, have assistants pull on nerves too much. You're not allowed to damage arteries. And the stuff I've had would be something where a patient's had a humeral fracture. The surgeon's left it a bit, gone in late, it's all scarred up, pulled on it, and the axillary artery tears. And then he goes, oh God, go in there, God, do something, call it. You know, I'm not saying this, it's all there but for the grace of God stuff. I may sound like it, believe me, and this is there but for the grace of God stuff. But unfortunately, I showed you that picture, the brachial plexus is right there, and unfortunately, they grabbed the brachial plexus as well. So, okay, so damage to arteries and the plexus. Fracture surgery, failure to reduce it. This we get as well, where they basically tried to do the operation, but actually the bones aren't back in the right place. They've not put them back. They've not done a good enough job. And again, on the next day, you think, oh gosh, this is still a bit low. The answer, I'm so sorry, sir. I'd hoped to, but it's not good enough. I'm going to take you back and try and put it right. Or, I'm sorry, I don't think I can get this right. I'm calling my friend who's better, or no, better still, I'm going to send you to this hospital where they've got a man who's very good at putting out. Sorry, it's necessary. You will never hear from the patient again. Just give them the chance of putting it right, but they don't. They just, and they know the next day. Failure to hold a fracture. So that's happened as well, where they do the operation and a few days later, a week later, it falls apart. They haven't put in enough screws or fixed it properly. Screws or nail in wrong place we've mentioned. Well, I'll show you now. And then joint replacement surgery. This is another thing where, again, I said to you, you've got to put the right thing in the right place, in the right direction. You know, this is all stuff. Arthroscopic anchors, these are these clever things. Finally, the last part of my talk, some examples of things where, the cases I've had where things have not gone well. This is a posterior dislocation. Okay, it just is. Sorry. And this is looking from the top. This is a CT scan looking from the top. So there's the socket, there's the ball looking from the top. And actually it's worse than that. This is snapped off. You see, this should be here. It's actually, there's a break here, there's a break here, and there's a break here. Now, for whatever reason, the surgeon saw this break here, but didn't see this. So he fixed that bit. Sorry, he fixed this bit with 2 screws, leaving this out the back and broken. So that wasn't going to go well. So there's that. He's still got out the back, dislocated, but he's had his little fracture at the front fixed, which didn't need fixing. So unfortunately, it all became arthritic. It's all a bit tricky. So the surgeon put in a new shoulder. The problem with that is that it's too high. This is too high. It needed to be lower. And this is the one that they then had to have it revised to this one. This was too high. This was lower. It's better. So several defendants. So missing the dislocation, badly fixing the dislocation, it becoming arthritic, having a shoulder replacement done badly, having to be revised again. This is, if you tear your biceps and you want it, and you don't want this deformity, you want it sorted, do a thing called a biceps tenodesis. This word tenodesis means tenotomy is cutting a tendon. Tenodesis means putting it back into a reasonable place. And the way we do that is with an anchor. And this anchor here, that is supposed to be there. But the surgeon didn't realize he'd put it across the joint. So it gouged away at the joint. It caused some secondary arthritis. As a pilot, your boy of 30-something wants to be a pilot. So that's settled. This is a bit abstruse, but this is a broken shoulder. Here's this bit at the back here. We're looking from above. This again, the CT scan, looking from above. This is off the back. It's supposed to be here. Here's the surgery. Here's the plate. This is still in the wrong place. This has a muscle attached to do this. This patient couldn't do this, settled for 400,000. And that was only because he had a bad back. Otherwise, it would have been more. They managed to get down because he had a bad back and wouldn't have worked for so long. Here's a collarbone fracture, and for various reasons, and again, I have sympathy for the surgeon, he put these two screws in too long. You can see they're too long. Now, running under here is the subclavian artery and vein. Yes, yes. So this patient got an arm DVT and inflammation of the plex. It was all a disaster. Here's a nail that's supposed to be, this is a fracture I showed you before. Here's a nail that's supposed to be there, but oh dear, this one's not been put in low enough. So this is gouging the rotator cuff and over here. So again, it's indefensible. Here's another one. This is supposed to be here. That's what it's supposed to look like after you've finished your fixation. Sorry, I'm not talking to you at all over here with these pictures. It's supposed to be like that after you finish. You can see this has fallen off. In fact, it was never on. He didn't get it. He thought he found it hard and gave it and accepted it like that. So then what happens? It continues to fall off. Then it doesn't heal. Then he takes the nail out and says, you know what, I think it has healed. I do think it's healed. Until finally it was all put back on and so on. But this was what I suggested as particulars of claim. Failure to reduce the fracture, which was a breach. Failure to stabilize the fracture, because once you've got it, you've got to put it back and then hold it. Failure to diagnose that on the table, and failure the next day when he saw the x-rays to not take it back to theatre. Failure to diagnose the non-union. As it happened, he thought he would graft it. He did grafting, and it was all to that. It's settled. It's settled. Luckily, she did very well. She found a wonderful surgeon who put her right, and she was only in her early 20s. She was very young, about 30-something. Okay, this is fun. This is a lady who was about 80, and she fell and dislocated her shoulder. She dislocated her shoulder, as you can see, and it was out for a week or so, so they tried to put it back. And when they put it back under anaesthetic, it wouldn't, so it kept coming out. While she was asleep, it kept coming back. So I tell you what, we will pin it in place with 2 pins. There we are. So now it can't move. That's good, isn't it? Though the shoulder couldn't move, unfortunately the pins could. In fact, one of them decided to migrate into the chest. And still going. Still going. They then took the one out that they could still reach. And this went further. And in fact, I could tell you, they took the other one out from under her left armpit. They could feel it in the left arm. They took it out. She did not turn a hair. She had, this business didn't cause her any, it caused a bit of a cough initially, but then she was all right. Honestly, she was fine. But it was a good case. Here's another one. This was a non-union and a bit of avascular necrosis. So the surgeon put a new prosthesis in, and I've lined them up so they're roughly the same height. roughly the same height. But you can see this is too high. This new one is too high. Even you can see it's too high. So needless to say, she couldn't really lift her shoulder very well. So she went to have it revised. And the surgeon had his registrar take the other prosthesis out and take out the cement, because there's cement here as well, just accept the cement. Take the cement out of there, and then he went back. The problem was that when he was taking this out, because he needed to get this out and to get a new one in, because this is high, this is high too, the tip is high, therefore the cement beyond it is high. Which means when you come with the right one, you're not going to get it and it's all blocked, so he had to drill out this plug of cement at the bottom. Unfortunately, when he drilled out the plug of cement, it skated out the side, the drill skated out the side, but he didn't kind of realize. The consultant comes back the week later, so right, we're going to fix this. He puts the new prosthesis in, puts in the cement, and unfortunately it leaks out the side. It leaks out the side here. Cement is hot. Cement polymerizes. It's a catalytic reaction. It gets hot. And you've now become anatomists. You know what's here. The radial nerve. And it cooked her radial nerve. She woke up with a wrist drop and dreadful radial nerve neuralgia. So they realized, they went and chipped the cement off her radial nerve. She's not done badly, but you know, this was all because this was unacceptably too high. Same trust, luckily, so only one defendant. This is my last one. I told you about ACJs. If at 3 months you've got this riding high, yeah, it's riding high, you had enough in it, so now you're digging, you're not happy. We do a thing called the surgilig procedure. It's working one of many techniques where you put this ligament round here, this thing called the coracoid, round here, and you lash it down, and that works fine. But you are now anatomists. You know that the brachial plexus runs quite near here. In fact, there's a very well-known American shoulder surgeon called Charles Rockwood, and he teaches his trainees. He says, this is the lateral side of the coracoid, and this is the suicide of the coracoid. And here's this brachial plexus running along here. So this was done, and unfortunately the patient woke up with dreadful nerve problems. This is the MRI scan. I know MRI. If we look at the one I'm going to show you two. If we look down here, you can see this is the right brachial plexus running down there, right brachial plexus. And on the other side, the brachial plexus is coming round here, up and down, just here and down. Here's the plexus here running up and down. And unfortunately, surgeons caught it with his surgilig and lashed it into the coracoid, caught the brachial plexus. And this is the patient trying to make a fist now. Yeah. So it's all there but for grace of God. I know, I promise you, it could all be me, really. So there we are. That's a run through it all. I hope that's given you some broad understanding of shoulders. And I didn't mention frozen shoulder. Frozen shoulder is a capsulitis. Frozen shoulder is when when the capsule, the hammock shrinks. We're getting there. That hammock thing, the person sitting on the hammock, that shrinks, and basically it's like having your jacket sewn up. Almost there. There it is. It's like having your jacket up, and it becomes terribly inflamed. And actually, frozen shoulder isn't that much a source of negligent problems. Just people get it, and people get it. The Japanese call it gochokata, which means 50-year-old shoulder. That's all the Japanese I know, actually. And it means 50-year-old shoulder because it comes about the age of 50. So it's basically a capsulitis where this capsule shrinks and becomes really tight, and it's terribly painful. Yes, always gets better. Okay, I'll take any specific question just to clarify something before, and we'll do the big questions later.
So I'm going to just pass this. Is that working? Yes. There's a question.
Hello.
Hello.
Going back to the posterior shoulder
Yes.
dislocation. So I have a client who sustained one of these, and then there was a 4-week delay in diagnosing and treating it, and he had an open reduction.
Mm.
But within 3 months of that, he started to develop infection and septic arthritis. And I wondered, whether the cause can be related to the delay in diagnosis, or is it just the open surgery, or...
He's got out of jail, hasn't he, really?
Poor guy.
I mean, the defendant's got out of jail. Obviously, it's indefensible, the 4-week delay. Infection, is it a new intervening act, or is it related to the delay in doing the surgery? It's probably a new intervening act, I'm afraid.
Oh well, thanks.
How do you treat a frozen shoulder then? Is it physio, or does it just get better by itself?
No,
or?
the cornerstone, I'm pleased to say, physio works, but it's very, very painful. No, cortisone injections are extremely powerful for this and get people out of jail. It gets better over between 18 months and 3 years. It recovers on its own. It's only because it's your aunt, isn't it? It's nothing to do with negligence. Between 18 months and 3 years, it gets better on its own. So you're just damping it down till it gets better anyway, and you're trying to convert a painful stiff shoulder to a painless or relatively painless stiff shoulder until it recovers on its own. We do manipulation under anaesthetic. We do capsular releases, and we do all sorts of stuff. Anyone with a painful front should see a surgeon because we really can help them through it. And it's dreadful. I mean, the only patients that burst into tears in my clinic room, other than looking at me and things, are the frozen shoulder patients. They are in such pain.
Thank you. Have we got any other questions? No questions? No internet questions? Just one. What's our question?
How does bursitis develop and how to treat?
Yes. Yes. Hello, Adrian. Bursitis, and just to help you with this, let's see if I can find a picture, because there is a picture which may help me just very quickly. I'll just find you a bursa picture. Fundamentally, where the body, I'm just hopping through to the bursa question, it's the chromoplast. It's really almost there. Where's the impingement one? Where is it? Where is it? Sorry, right there. I've gone too far. I'll be 1 second. Then here. I mentioned before, and this again could be a pink slide, because all bony prominences around the body, almost all, have a sort of pillowcase thing lying on top of them. And they have them in front of the knee, so there's 6 or 7 around the knee, around the elbow, in the shoulder. And they're little pillowcases like that, and that stops the bone grinding through something nearby. And that pillowcase thing is called a bursa. And it should lie like that, like a pillowcase. But occasionally, something inflames it, upsets it, and so the bursa then makes fluid, and so it becomes like that. It swells up. And that's called a bursitis. Now, we have the impingement, we have the tendon here, we have the bone here. So the rheumatologists like to call this tendinitis, because they can inject cortisone and get them better, or bursitis, because the bursa is right on top of the tendon, so that gets inflamed too, so they call it bursitis. We call it impingement, so we can operate and remove the bone because it's rubbing, it's impinging, it's catching like a door not closing. So we can free it, but it's all the same thing. Okay?
Well, thank you very much, Michael. Utterly exhilarating. So we're now going to go to Michael Pearse, who's going to look at orthopedics from a different angle. Michael.
Thank you very much. Slightly different angle. So we're going to largely go to the lower limb, but I think we'd all agree that earlier talk was very erudite and does away with this notion that orthopedic surgeons are strong as an ox, but only half as smart. So I just want to get this out of the way, because we can now, Michael has shown you some good data, and I can show you data that shows that orthopedic surgeons are not so thick. My junior doctor, a couple of years ago, compared the IQ and the strength as measured by using a hand grip device between male orthopedic surgeons and anaesthetists. I mean, okay, we're starting from a very low base, I'll admit that, but the results, as you can clearly see, not only are orthopedic surgeons stronger, but they're cleverer as well. So in fact, we're perhaps as strong as an ox, but maybe twice as smart. So I just want to get that out of the way, just a little ego massage. So much as the earlier talk, I'm going to base a lot of what I'm going to say on this fairly extensive review of a lot of litigation cases in the United Kingdom. And around that, I'm going to pick out some common orthopedic problems, primarily in the lower limb, but not exclusively. I'll touch on the spine, but I'm by no means a spinal expert. Orthopedics is very simple, which is perhaps why we've got this reputation, and the great late Alan Apley used to say it's very easy, you just look, feel, move and x-ray, and that's all there is to it. So your client comes in and he's very upset with Sainsbury's because they spilled their grapes and he slipped on one and now he's got a swollen knee, which you can all see here. So we've had a look. So if we put our hands on that knee, he said it hurts on the inner side, and then having felt it, we try to move it. He says, ouch, that hurts, as we put it through a specific movement, and we're thinking a meniscal tear. But now there's no excuse because we have MRI scans, which really are incredibly accurate, more accurate than probably the orthopedic surgeon when he looks inside the knee joint, and it should stop unnecessary surgery. So we know from everything that what this patient has and what they need, and that's arthroscopic meniscectomy. And we communicate that to the patient, as you've heard. We write it down. We tell them what could go wrong, and we write that down. And there's this very patient, and that's his bucket handle tear, which is stopping his knee going straight. The hinge joint, that is the knee, and we need to take that out, and he's better. But we've heard about some interesting trials in the earlier talk, and big data is really changing the way orthopedics is practiced and the way your clients should be treated. So when it comes to arthroscopic surgery of the knee, well, that really was a big earner for many orthopedic surgeons. And orthopedic surgeons, certainly in London, that just do knee surgery, we call them knee tarts. That's all they do. And everybody needs an arthroscopy. Well, now we know they don't. So they've done a study where one group of patients had a pretend operation. They woke up and they even had an incision, but they didn't have an operation. And the other group did. And what they showed, there was no difference. Much like the study on the fixation of some of the shoulder fractures, further data has come out which shows that, in fact, when someone's got a bit of osteoarthritis and a degenerative tear, and you take away the degenerative tear, you can make them worse. So the New England Journal of Medicine, one of the highest ranking journals in the world, and then a couple of years ago, British Medical Journal as well. There's no room now for washing out a knee joint. So if one got infected, for instance, the operation shouldn't have happened. And of course, Bupa are onto this now. So if we want to do an arthroscopic meniscectomy of a knee, we have to get permission, because Bupa, I think they did the same with hysterectomies, are trying to limit unnecessary surgery. And we do have to support this because the data isn't there. What about the spine? I'm just going to touch on this briefly. So spinal surgery is pretty uncommon. Spinal complaints, litigation is very common, and big payouts as well. It all goes back to the 1940s in the United States. Mixter and Barr realized that the disc, when it prolapses, could press on a nerve and cause sciatica. And this was published in the 1940s. Within 5 years, there were thousands and thousands of discectomies being performed in the United States for the wrong indications. So much so that 10 years later, Mixter published another paper saying, we were wrong. We've caused mayhem, but the damage was done. So there's a lot of unnecessary spine surgery. Again, we are applying big data to this, and the protocols are coming in, but there are a lot of unhappy patients out there, many of whom I'm sure you've met. So all these problems, when you get the patient coming in and they're complaining, and everything hurts when you touch them, and you can easily distract them, and there seems to be an overreaction. These so-called non-organic signs were originally described for failed spinal surgery. So it really doesn't have a very good press. And this definition about the influence of compensation and the law on a medical condition was actually quoted back in 1891. So this has been a problem for a long time. And in fact, one clever chap has put a name to this problem, normogenic disease, and we do see this with whiplash and compensation with a so-called back injury at work, and it really is very difficult. I certainly don't have any answers for this, and when you get a patient who's complaining and complaining, and the shutters just tend to come down until you can get them out of the clinic. And one of the problems is no one in this room who would have an MRI scan would have a normal MRI scan of their back, because there would be some abnormality detected on the MRI scan, which is so sensitive. The problem is all these abnormalities that we all may have no relation to low back pain, no direct relation. They're equally common in patients who don't have low back pain. And the other issue is when somebody tries to tell you, oh, I slipped my disc lifting up a sack of potatoes or something, disc herniation is not really associated with injury. Okay, it's a complex phenomenon we don't fully understand, and it tends to occur in a certain age group, but the association, certainly with repetitive bending and so on, is very uncommon. And of course, back pain is very common. It's so common, it's probably normal to have a degree of back pain in your life. It's a design flaw. When we came down from the trees, there's an awful lot of pressure where the flexible lumbar spine meets the pelvis. It's not necessarily an injury. And is it related to work duties? There is no evidence to support that it is. One massive study looking at patients who were insured for compensation compared to those that weren't insured only related work problems in a third of the time, whereas those that could get compensation, not surprisingly, 90% were thought to be work related. And this contrasts to well-motivated patients, such as the famous study of the Swedish pilots. They had a number of injuries, all got back to work despite severe spinal trauma within months. So it very much depends on the psychological status of the patient. And that's why after this big Volvo study, a lot of big companies now are employing nurses. So when somebody gets back pain, you ring them up and you say, we really value you. You give them physiotherapy straight away. You don't encourage them to take time off work, and you try to get them back in and make them feel a valued member in the workplace. So an awful lot of this, unfortunately, is psychological, which is why all big back pain services have a psychologist in the clinic. You need them for the surgeons, never mind the patients. You have to be mad to do spinal surgery. But cauda equina, which is Latin for horse's hair. So this is the terminal part of our spinal cord. And of course, if that gets compressed, it's a disaster. It's very uncommon, but complaints and litigation are common, and there's a number of reasons for that. There should be this year national guidelines published, which will clear up a lot of the difficulties that are currently being experienced. So typically, you get severe back pain, which is sudden in onset, and then as the discs go forward and they start compressing on the nerve, they get a classic numbness in the saddle, so-called saddle distribution. The pain starts going down both legs, and that shooting, sharp pain, so-called radicular pain, which is very severe. If it goes below the knee, it's sciatica. If you get just a bit of numbness in your thigh or the back of your thigh, that's not sciatica. Sciatica has to go down below the knee. And these are the warning signs. And there's no doubt that the sooner compression of the nerves is decompressed, the better. It is a bit controversial, but that is an indisputable fact. So the issues are, you're at home and you get your problem. You contact your GP or you present to an A&E, maybe a small A&E. The MRI scanner might be in another hospital. The spinal surgeon is in another hospital. How often do we have to go to the toilet to have a pee? How many hours passes on average before we have to have a pee? 3 or 4. Some people be 3 or 4. About 6. Okay, if you can't pee after 6 hours, you've got a problem. And it's something to bear. You're not taught that in medical school, but it's actually really important. So overnight, I can't pee anymore. So I might wait a few more hours, and of course the compression has started. Then you tell your doctor, and it takes a long time to get a specialist involved. Then you've got to get an MRI scan, and of course the clock is ticking. So let's have a case then. So this is a true case. So this is a 40-year-old lady, long history of low back pain with all the psychological problems. She might turn up in casualty. Nobody wants to see her. She was going to have, you know, a lot of issues, but she's developed pain going down both legs, okay? GP saw her, didn't think that was a big problem. That night, she lost the ability to pass urine. So she waited until the morning and she called the GP, didn't visit till the afternoon, and then he documented saddle numbness, but he forgot to put it in the urgent referral note. She gets to hospital, she sees a junior doctor who for some reason records rheumatoid arthritis. She's admitted, nobody looks at her for 48 hours. Now she can't, now she's fetally incontinent as well, and she's lost anal tone. The damage is done, okay? And then she's got to go to another hospital where the spinal surgeons are. So spinal surgery is now concentrated in a very few centres, and this was a substantial settlement. And so this is a fairly classic case of cauda equina. Well, we've seen a fracture of the humerus, and they've all been fixed. Well, here's one that isn't fixed, and more than 90% should heal without fixation with this wonderful natural process. And let's not forget that every time you cut a muscle, skin, they'll heal by scar tissue. Bone is the only tissue which heals by replication of the host cells. It is truly one of the wonders of nature, and we can manipulate this process to the benefit of our patients. Michael didn't have a functional brace to show you, but we put this on to get the patient to keep moving their muscles and their joints to reduce stiffness and overall disability. And this is the sort of classic conservative treatment of a fracture, which is, will bring about optimal function. To diagnose injury, as we've heard, is fairly straightforward, but you have to put your hands on the patient. So if we're thinking about ankle fractures, common source of problem, as we saw in a slide earlier, and it's because they're not examining the patients properly. So this is a rugby player who's got tackled, and now he's got a painful ankle, and we want to know, is this a ligament sprain or is it a fracture of the malleoli, which I'm sure you've heard about? And there are special Ottawa ankle rules. They're very simple. If you press on the bony bits and it hurts and they can't walk, get an x-ray. Not everybody needs an x-ray, because a lot of patients will just have a simple sprain and they'll get better no matter what you do. And so often this is missed and it leads to problems. Here's a very simple fracture. You can see a crack there. You can do anything to this or you can do nothing, and the outcome will be good. This is our rugby player, and you can see they've got a nasty fracture here. There's an important ligament here that holds the bones together. That's ruptured. This bone, the talus, which is on top of the foot, is beginning to drift. So they need internal fixation or ORIF with a syndesmosis screw. They need more aggressive treatment. Well, we're often asked, you know, what's the chance of getting osteoarthritis? Well, pretty much zero after this sort of injury. But here you can see it's much more severe. You've got shear forces, that cartilage is damaged. Probably more than 80% chance of getting osteoarthritis. But in general, osteoarthritis after an ankle fracture is uncommon. And if you're going to get it, you tend to get it within 2 years. So here's a case in point. This is a 57-year-old woman, falls over, goes to the A&E, gets an x-ray, no bony injury, wrapped up in a bandage, goodbye. Now that particular hospital didn't have the backup of a radiologist looking at the x-rays. You do wonder what these patients do out there. Anyway, 4 years pass. She has been to a doctor a few times, but the doctor doesn't always record what happens, but still got ankle problems and not getting better. Finally, she decides to sue, and she did have a bimalleolar fracture on both sides of the ankle, which moved. She got early onset osteoarthritis, so that settled for quite a substantial sum. And both the junior doctor at the hospital and the local health authority were criticised because he didn't have the backup of the x-ray reports. Just a quick bit on Colles fractures, very common. You fall onto your outstretched hand, the back of the wrist goes backwards, and you look like a dinner fork. Your wrist suddenly looks like that. It's a very straightforward injury. And it's interesting, these injuries were described hundreds of years ago. This one was described in Dublin in 1815, many years before the advent of x-rays, by Abraham Colles, who was a professor in Dublin. The posterior dislocation of the shoulder was first described in about 1840 by a French surgeon, and he said it's a deformity that cannot be missed. Yet it's one of the commonest reasons why A&E doctors get sued, because they don't examine the patient and realize that the limb is internally rotated and they can't externally rotate. Low-tech treatment, just give it a pull, shove these K wires in. You might think, where's all the plates and screws? Well, we've had the studies on the shoulder fractures. Now we've got the studies on the Colles fractures. So this was published recently, 450 cases. You opened an envelope and you either got cheap Kirschner wires, 50 quid, or you got an expensive plate and screws, 750 quid. 12 months, absolutely no difference. So I think as far as you're concerned, if you've got a patient who's had a plate and they've got a tendon rupture or an infection or some other problem, and then you may wonder, well, why are they doing treatment that is overcomplicated and more associated with complications than something more straightforward? And let's not forget, there's no condition in the whole of medicine that can't be made worse by surgery. Colles fractures, this Swedish outcome study, of course in Sweden nobody goes anywhere, everyone lives in the same place, they all know each other. They've got 30-year follow-up studies. Most patients couldn't remember which wrist they broke. Osteoarthritis is very uncommon, but you put a plate on, get the screw in the wrong position, your patient can have or your client could have a problem very quickly. So I think we are guilty of over-treating a lot of conditions, but the application of science is rationalizing what we do, as we heard in the first talk. So here's a poor chap. He fell outside the GP surgery. So he went back in and said, oh, look, I've done my wrist. He probably had a dinner fork deformity. And the GP said, oh, I think it's a sprain, don't worry. We call that fanning it with a hat. So he didn't get really any treatment at all. 4 weeks later, it's still swollen and it's still painful. And someone actually says in the accident department, it looks like a dinner fork. And he's got the x-ray which shows it's displaced, but of course it's healed now in this fracture. So things are going to be difficult to correct. So the expert said, this is not good. This needs to be settled. We didn't do this man any favors. Going to more high energy injury, and this is a common problem. Patients in the UK move around an awful lot. They're very mobile, literally on their motorbikes. This guy comes off, he's broke both wrists, and he goes to one A&E, and they put local anaesthetic in and give it a pull, put the casts on, and say, right, off you go to your local hospital. But they haven't discharged their duty of care. They need to really do as much as they can to make sure the next hospital know about this patient, because this young man is going to need surgery, because these are unstable fractures. The unstable nature wasn't recorded when he came back at their follow-up clinic. He finally gets to his local fracture clinic beyond 2 weeks. By this stage, the fractures have slipped again. It's all a lot worse. He needed complex reconstruction. He did have a good outcome, but the claim was settled. The initial treatment was not acceptable. So there is a duty to make sure if you are sending a patient to another hospital that all the stuff goes with them. And of course now that's easy over the internet, and we can send all the x-rays as well. So let's talk a little bit about neck of femur fractures. So here we have the intertrochanteric fracture with a DHS, a dynamic hip screw. It's going to slide. On the other side, they normally have a matching pair, but this patient's got a proper neck fracture, intracapsular. So we'll treat that with a hemiarthroplasty. If they were 65 or 70 and still shopping and playing golf, we might do a total hip replacement for them. And this is a common injury and also a common cause of problems. Again, we've got national guidelines, so everybody who presents with a neck of femur fracture, from the time of presentation, not necessarily diagnosis, they must have full treatment within 36 hours, or that hospital doesn't qualify for the payment for their treatment. So the emphasis now is on quick diagnosis and quick treatment for these vulnerable patients. Probably the biggest problem is where the fracture hasn't displaced and it's not so obvious on x-ray, and the diagnosis is often delayed. So if we compare these two sides, you can see there is a subtle difference. So probably a 60-odd-year-old female, she's got pain, there should be a high index of suspicion, but all too often there's a failure to take an x-ray or a failure to do anything else. And in this situation, an MRI scan is the gold standard for diagnosis. But because of the pressure for cancer and other things, and all these shoulder complaints, quite often the patients can't have an MRI scan and it's missed. Well, that ball will fall off if you send that patient home. And of course, the whole injury is a lot worse, and they can successfully sue. This particular patient was fixed in situ with multiple screws. So these are often the problems, neck or femur fractures. Other issues, of course, we've got vulnerable patients. Pressure sores should not happen, but they still do. And when you put a patient on the table, you've got to paddle the areas. They can get a foot drop because of pressure on the outside of the knee where the common peroneal nerve is. I've been referred a number of these. Again, it shouldn't really happen. This poor lady actually worked in the hospital, and she was on her way out when she slipped. She couldn't weight bear. She was in pain. They didn't even x-ray it. I mean, there's just no excuse for that, really. So she couldn't walk. She borrowed some crutches from the ward where she worked. She fell off them. She gets an x-ray. Now it's displaced. But because she was relatively young, they decided to try and fix it. That didn't work. So a year later, they'd taken the metalwork out. She gets her third operation, which is a total hip replacement, and the hospital had to settle. She couldn't get back to work. Here's another one. This is more higher energy. Obviously, the faster the patient's traveling, the more likely they've done something wrong. She's involved in a car crash. Her daughter carried her into the hospital in hip pain, diagnosed with bruising, no x-ray. A week later, she got a GP, got the x-ray, showed an acetabular fracture. For some reason, the orthopedic surgeon thought it was a stable one. He got her up, got her walking, and 3 weeks later, she came back. It had displaced, and I've got the x-rays here. So you can see at the first week, there's a tiny little crack in the hip joint there. A few weeks later, rather than getting that fixed or being treated on bed rest for 3 weeks, she now needs a complex total hip replacement. So she's successfully sued. Basic errors in management, really. Talking about the hips, of course, in the younger patient, there's the slipped upper femoral epiphyses. These tend to be kids between the age of about 8 and 12. They're almost invariably large. They do often have minimal trauma, and the top of the thigh bone slips backwards, but they present with knee pain, and there's often a delay in diagnosis. But there's no excuse with this poor lad. He fell out of a tree and he couldn't walk, saw the school nurse who gave him paracetamol, saw his GP. By this stage he's complaining of knee pain because the hip and the knee share the same nerve supply. So they may complain of a knee problem, but it's actually arising in the hip. He just received advice. 3 weeks later, he gets sent for physio. 6 weeks later, his mother finally drags him down to the local A&E where they realize he's got a severe fracture. And here it is. And this is the, so that's the capital epiphysis. There's growth going on there. That slipped, as you can see on this side. Well, this now is a complete disaster. He was referred to a specialist hospital where they tried to reduce it and put screws in. But this just died away. It lost its blood supply, so-called avascular necrosis. And you can see the screws are now sticking out. This kid was still a teenager. So now at the age of 19, he's had a hip replacement. So this obviously was settled for a fairly sizable sum. Going on to some soft tissue injuries, Achilles tendon rupture. This is a really classic injury. Someone's playing tennis, often doubles, and they hear a pop and they think someone's kicked them from behind. And it's a sudden sharp onset of pain, and they limp, and there's a little bit of local swelling. If you lie them down on their front and you squeeze the calf, the foot will not move because the tendon is no longer in continuity, the so-called positive Thompson test, which is not that accurate, but it's important someone's performed it because they're thinking about it. The real issue here is that up to 1 in 4, the diagnosis is going to be missed, and yet it's so classic. My sister's a headmistress, and one of her teachers was taking the kids out, and she sustained an Achilles tendon rupture, and she started to sue the school because one of the kids had kicked her in the back of the heel, which of course they hadn't. It was just a classic injury. She thought they'd done that and run away, until I explained that this is often what patients complain of. Again, there's been a lot of recent research. Previously, everyone had this operated on, but now we've got randomized studies and big data. We know that surgery can be associated with a lot of problems, and it tends to be reserved for high performance sports individuals. So if you put this in a splint and get early rehab, the results are just as good. But the gap has got to be below 10 millimeters. Well, if the diagnosis is delayed, you get a bigger and bigger gap, and they're more likely to need surgery, so they miss the chance for conservative treatment. And if it's a big gap, they need a big reconstructive operation. So the implications of delayed diagnosis are quite significant. So here's such a case, a 50-year-old, the classic popping of the heel, went to see the GP. It's a sprain, you need physiotherapy. The delay getting physiotherapy, but they immediately diagnosed an Achilles tendon rupture, rang the GP, organised the scan, another 3 weeks. So it was 10 weeks before this patient had surgery, by which stage there's a big gap that's got to be closed, and there's a lot of techniques you can do, to close the gap, but it's not called the Achilles heel for nothing. And the healing there is very poor, and the risks of infection with surgery are very high, and you get pain and numbness, and it's not ideal. So early diagnosis, straightforward treatment. Here's a young male, he's come off his motorbike, he's sustained a mid-shaft tibial fracture. The bone has come through the back of the calf. The calf is very swollen and shiny. He's in a lot of pain. What do we think might be wrong with him? He's got pain out of proportion to the injury. He's been given morphine, he's still screaming.
Just use the swelling up.
Swelling up. Compartment syndrome, which is a limb-threatening complication, typically of trauma. There are other causes. So when the pressure in that tight muscular compartment goes up, the blood supply is reduced, and you get loss of oxygen, ischemia, and then severe damage. And it's classically an injury of youth because they've got good muscles. So Saturday afternoon, pub football, clash of legs, they're typically the sort of patients that will get a compartment syndrome. Early diagnosis and decompression is essential. And it's, again, a high index of suspicion, and it's that pain that's important. If you're in doubt, if a patient's on intensive care, they're on drugs, you're not sure, you can pop a needle in and measure the pressure and relate the pressure to the blood pressure. So diagnosis is fairly straightforward, but not quite invariably, but certainly before we had trauma centres, which changed so much, the diagnosis was commonly delayed, which would lead to a lot of problems. You would then get scarring and the dysfunctional limb, pain, and often amputation may be needed because the foot would be useless. So it all arises because of a failure to examine the patient properly. And this was the guy whose picture you saw originally. He's got skin grafting, and at 2 years the plastic surgeon can excise that and close it directly, but you can see the leg is still swollen. So here's a case in point. This is a classic 21-year-old footballer. He's got a tibial fracture. They've decided to put a rod that you saw, an intramedullary nail down the middle, but they've run into problems. And they bashed the nail in and didn't go in very well, and it got stuck, and now there's a gap. So they've stretched the leg a bit. So he goes up to the ward where he's screaming in agony. It's recorded in the notes. He's still in pain despite morphine, but he didn't get a fasciotomy until the late following afternoon. And all the time, the anterior muscles have lost their blood supply, and look away now. So he's lost the whole of the extensor compartment. He'll no longer be able to pull his foot up. We might be able to do a tendon transfer, and he needed a free flap. So he got a very nice cosmetic result. So they took his latissimus dorsi with skin and anastomosed it in there. So it looked very good. And the family, I mean, his brother had a heart transplant. It was, it's an absolute nightmare, and it is preventable. So great tragedy, real problem. Open fractures, like we saw previously, we have the techniques now to get really very good results. This is a surgeon. He's a tree surgeon, and he's fallen out of his tree, fallen off his perch, like a lot of us do, well, particularly upper limb surgeons, isn't that right, Michael, when they're older? But so very straightforward. He's got probably damaged the skin, so we need our plastic surgical colleagues involved. We put a rod down the middle, Look, there's no gap. He's joined already. He's back at work 5 months. We can get really nice results, and he's got a local flap to cover the hole in his leg. Going a bit more high energy. It's interesting, all these, we see a lot of shotguns who work at St Mary's in the trauma centre, and everyone's sitting at home reading their Bible, and someone come up and shot me. I don't know what it is about the Bible, seems to cause a lot of problems. But you can see we've got high energy here. Look at all these bits, okay? So we need to do something here. So there's the entry wound, that's the exit wound, and all these bits just fell out. They've got no blood supply. So what we're going to do, we're going to create a fracture, this marvellous process, and we're going to manipulate it to our advantage. So we put this frame on, which is not very nice, but keeps him out of mischief. We were able to close the wound because I shortened his leg. We cut it at the top, wait for this wonderful callus to form, and then we stretch it to restore the integrity and the length. And here he is some months later with a new bone forming, and I think we had to bone graft him down there. So long, complicated treatment, but really good outcome. And he came back to see me, and turns out he's quite a good 400-meter runner. I said, oh, can you send me some pictures of you training and back running? So here he is, back running, away from the police actually, probably. But he got quite a good outcome. So it's not all terrible. It's not all doom and gloom. We've heard about these definitions, so I can nip through them. So if you don't get it straight and it's a bit wonky, malunion, that's a problem. It can be a problem. And this is the one we all dread, when the fracture gets infected because it's not going to join, and it's, you know, your fixation's failed as well. So big implications. But again, we can do some wonderful things for that. So this lad had fallen off a balcony. He's got a non-union. His foot's pointing the wrong way. He's leaking Staphylococcus aureus, a common bug, but he wants to heal. So maybe if we manipulate that fracture site, pull it apart, twist his foot round to where it wants to be, and the body will heal. So I think if we can get the biology and the mechanics right, we can do good for these patients. But it doesn't always go well. This is a mid-shaft femur fracture. This guy's come off his motorbike, the bone came out, stuck in the road, or bits of grit in there. He was taken to theatre. This intramedullary nail was put down, but like that earlier case, it didn't go well. And you can see there's a huge gap there. And then 2 weeks later, we were asked to see him because there's pus coming out of the wound. He's got the dreaded MRSA. So this has got to be jumped on. You've got to get in there, clean it up. And then you've got to stabilize the bone. His femoral nerve wasn't working, which meant he couldn't straighten his knee. So we weren't going to put an X-fix on this. So we put another rod down. Here we are at 2 years. The CRP less than 1, completely normal. The nerves recovered. We're feeling and thinking everything's great. Well, 4 years later, he came back. The CRP was up. He had a temperature. The infections come back. So here we are, nails out. We're making a hole in his distal femur so we can lavage it and ream it and wash it. And this is the implication of orthopedic infection. It doesn't necessarily go away. It will come back and haunt you. So it's a big problem. It's a very expensive problem. It should only occur after closed injuries, after closed treatments such as joint replacements, around 1%, up to maybe 3% depending. And it's not often treated ideally. For some reason, the diagnosis is often late, by which time the treatment has to be more aggressive. There's a failure to look at results and act on them accordingly. You heard in the first talk, surgery is required, not just antibiotics. And there is a reluctance for some reason to dive in and do that. I'm not quite sure why. So here's a chap who's had lots of problems with his knee. He'd already had multiple operations, a fracture, surgeries, and he said, you know, it got infected a couple of times. Now he's got arthritis, listed for a total knee replacement. Well, he shouldn't be. You should take biopsies to see, is there infection there? Because it will be dormant. It won't flare up until you operate on him. That didn't happen. They got in, they was doing the surgery, and they said, this looks a bit funny. So they took some biopsies, sent it to the lab, but nobody looked at it. No one checked the result. And they put a knee replacement in, which you say, well, this is a potential disaster. A few weeks later, not surprisingly, he comes back, it's leaking, it's swollen, the wound's open, and it's discharging. Now they look at the result, and it was positive for infection, but it wasn't checked. So he now needs a 2-stage revision. So the experts quite rightly said this guy wasn't given the risks of infection. In view of his previous surgery, he was a high risk. So you have to say it, you have to write it down. We all know about Montgomery and so on, but it's just good practice. They didn't even check the results. So a lot of errors. It's easy to be wise in hindsight, but this was a disaster waiting to happen. A little bit about cancer. The commonest cancer we see are the secondaries. They go to the bone, they cause pain, they fracture, patients can't walk or use their upper limbs. So we treat these very aggressively, so these patients have a high quality of life towards the end of their life. Quite often the bone pain is ignored, x-rays aren't taken, they then fracture, and the situation is more complex than it otherwise might have been, and the diagnosis can be delayed. One case in point, this is more of a primary bone tumour. The problem with primary bone tumours is they're uncommon and we don't think about them. But this young man had right shoulder pain and it was going on, and he'd seen his GP a lot of times, had physio. You know, if something's not getting better, we need to get some x-rays, need to get some imaging. Finally, they got an x-ray and there's a lytic lesion. There's a hole in his shoulder, in the acromion. Nothing was done. So they got a non-urgent CT scan. He had multiple myeloma, and a few weeks later he's paraplegic. So this is a disaster. This could have been aggressively treated and he could have had pretty good 5-year outcome. So we need to be mindful of when things aren't getting better, these patients need imaging to really assess what's wrong with them. So again, not surprisingly, that settled for a considerable sum. We're coming to the end then, total hip replacement. It definitely is one of the greatest operations of the last century. You know, it really can transform a patient's life, and the outcomes are really good. I'm sure you've all seen the reports. Oh, he's going to need a revision in 10 years. Nonsense. These implants, the majority of them are now functioning well out at 20 years. And this is standard data because we've all got to record our results, and they're all lodged on the hip registry on a central database. And I think provided we get the implants correct, we're not seeing a big increase in claims now that we've got over the problems with the dreaded metal on metal. And this is uncontrolled introduction of new implants, which was a big problem. What are the causes of problem? Well, we're talking a bit of detail about the first two. Implant positioning, the position of the cup. Many of you might have had patients or clients have had problems, and when it's too vertical, the hip might dislocate. More than 60 degrees is probably incorrect, but it's not well defined. We all have infection. It's how we treat it, it's how we recognize and act on it. Intraoperative fractures shouldn't occur. Hip replacements are either put in with cement or they're put in without cement. If you're in the theatre watching, when they put it in with cement, it's all very elegant. When they put it in without cement, there's a hammer and things are being bashed into the femur, and that's when fractures occur. And there's a lot of good data emerging now that more elderly patients should not have uncemented hip replacements because of the risk of fracture is unacceptable. And certainly in neck of femur patients, they shouldn't have uncemented implants. And that is becoming unacceptable practice. We're not quite there yet. And again, if they haven't got appropriate DVT prophylaxis and they get pulmonary emboli, then that is a common cause of complaint and claims. So sciatic nerve palsy, how often? Well, it used to be said it's really uncommon. I'm not so sure. We don't have hard data, but I don't know, no more than 1%. But if you consider we're doing 100,000 a year, 1% is actually quite a lot. So the patients need to know it's a potential problem. And we know there's an issue if it's not diagnosed. So a patient gets up and their foot is flopping, no one's picked it up, and maybe just before they go home, the physios notice that they're falling over. If there's a hematoma in the wound, a collection of blood, that can be pressing on the nerve. That patient needs to go back to have the hematoma evacuated, and failure to do that does not represent very good practice. If they haven't had a foot drop splint, it's not really been picked up, not very good practice. If they've not had nerve conduction studies, not very good practice. And if pain is a real issue, that is possibly an indication to explore the nerves. Certainly if they go to a peripheral nerve centre, they all get explored because you do find cases that have been constricted. You release the constriction, you improve the pain. So sciatic nerve remains a problem after hip replacement. Here's one unfortunate case, which young lady, I think she had a vascular necrosis. It's quite large. She went to a specialist centre not far from here, and she was operated on by a hip fellow, quite a senior, assisted by a junior. The consultant was in the coffee room. Post-operative, she had sciatic nerve palsy. Well, it gets a bit worse than that. It wasn't diagnosed during the initial admission. No splintage, no pain referral, no mention of the wound, no occupational therapy referral for the foot drop splint and so on, no nerve conduction studies. So she was sent to me. It wasn't just the sciatic nerve that was damaged. She couldn't straighten her knee. The femoral nerve was gone as well. We got nerve conduction studies which confirmed it. So, you know, this is not acceptable. And when you go break down the operation note, they had major problems. And then when the surgeons produced their witness statements, they admitted there were various issues which hadn't really been recorded. And not surprisingly, there was a substantial settlement. So these cases you really do need to go over sometimes with a fine tooth comb. Actually, she had a report from someone who said this can happen, which it can, rarely, but you have to exclude potential causes. Patients hate this. So they hate it when the legs aren't the same length after the operation. Unfortunately, it's quite common because getting the length right is an art, not a science. If you've got a twist in your back, you've got a twisted pelvis, surgeon's not having a very good day, it's very difficult to get them balanced. So you have to warn the patient that this might happen because they don't like it. And if they've got an ankle fusion, you know, they've had a previous operation, the leg might already be a bit short, or on the other side, you have to take that into account when you're putting the implants in. What is acceptable? It seems most hip surgeons think about 1.75 up to a centimetre. You don't necessarily notice it. Once you get over a centimetre, you do. Once you're over a centimetre and a half, you're pretty unhappy. So I think attention to detail and an informed patient reduces the problems. So this was a big disaster. We're still seeing the problems. And you know, we've got national guidelines that say we should no longer do this operation, put this metal on metal implants in, and some surgeons are still doing it. It's very naughty. But it's just instructive to think about why did it happen? And although it's easy to blame the surgeons, and we perhaps should have been a bit more careful before we introduced these implants on a wide scale, there was a huge financial incentive. There was a lot of money to be made. And a lot of hip, knee replacements and other surgery is driven actually by the United States because that's where a lot of the companies are based. And when you look at these articles, if you look down in the corner, there'll be a phone number for you to contact to have this. I mean, these are financed, these articles. This is Angie Best. I actually operated on her because she fractured her distal tibia, but she had to go to Birmingham to have this operation. Well, the results from Birmingham have been questioned and nobody quite believes that they're as good as they are, and this operation has very much fallen out of favour. And here's the data from the hip registry. You know, the revision rates should look like this blue line, and this line actually at 6 years is becoming a bit more vertical. But a lot of these cases have since been revised. Very expensive problem. A lot of very unhappy patients. Here's a patient, 46, had both hips replaced. She saw her surgeon and she was beginning to hear stories about problems with these metal on metal. And it says in the notes, GP letter, this is all media hype. These hips are going to be fine. The company then finally admitted there was a problem. They kept selling it in the Far East. It was the Australians that really picked up the problems a number of years before, and they published it in international journals, and still the implants were put in. So she was offered a revision and told that an MRI scan wasn't necessary. Well, the MRI scan, you have to do special settings, but what happens is metal on metal, the ions are produced, you get horrible inflammation that just destroys the soft tissues. So the muscles that hold your pelvis up when you walk just get eaten away. And it's a sort of destruction we hadn't seen before. We're used to holes in the bone, but of course if your abductors are gone, just like the rotator cuff that you heard about in the shoulder, the abductors at the hip joint are very important. If they're gone, it's not just that you're going to waddle, but your hip's going to be unstable as well. It's a massive problem for revision as well. So we're seeing this unique gross soft tissue damage. So she had it on both sides, and she had to have premature revisions on both sides, with implications obviously for further revision. Just to finish then, total knee, a similar sort of problem, possibly less. The scores for the knee replacements are not as good as the hip replacement, but they're getting better. Infection's a problem for the reasons that we've heard about. Ligaments are very important in the knee, and particularly the ligament on the inside of the knee is often cut. Foot drop shouldn't really happen after a knee replacement. Sometimes it does and recovers, but as you cut the bone, you can damage the nerve. Similarly, arterial damage obviously shouldn't happen at all, and intraoperative fractures shouldn't occur, particularly in the primary situation. So I think that brings me to an end. Thank you very much.
So, have we got any questions? Anyone got a question? Anyone got a question for Michael? No, it looks as though you've explained everything, Michael, and they can all carry out the surgery. Right, no questions? In which case, well, thank you very much, Michael.
My pleasure.
Thank you indeed. And we'll go straight into Julian Matthews, who's going to do the legal aspects.
Good evening, everybody. Fascinating talks. Thank you to both Michaels in respect of that. And in fact, they've covered quite a lot of the material that I was going to touch on. And the fact that it's duplication just simply means that we're all identifying that the same cases come up and the same problems are there. So what I'd like to just see if I can work this. Start with some statistics, which I think will be just quite useful to put what we've heard from the medical perspective into context. This is from the NHSLA, the National Health Service Litigation Authority 2015-2016 report. Claims made arising out of orthopedic treatment, and this may come as some surprise to you, represent by far the largest number of claims brought. This is not by value, but this is by numbers of cases. 33% of all claims made. In the 2015-16 year, there were over 10,000 cases brought, so 33% of those were in respect of orthopedic matters. Most of the claims, out of all of the claims made, and I'll come back to deal with this, were brought by those in the age range 40 to 60, and 56% of all of the claimants, and this was something of a surprise, not just the orthopedic cases, but of all claimants, were female. That one is actually reflected when you then come to look at the joint replacement statistics, which I'm going to just cover in a moment. Interestingly, again, from our point of view as lawyers, and it's the great work that our doctors do in medico-legal reporting and being able to be precise about that reporting and then holding to it when they get to joint meetings. Of 10,000 cases per annum which are brought, the NHSLA figures showed that 124 cases were taken to trial, so a very small number actually went to trial. There were obviously quite a significant number that weren't continued, but most were resolved without a need for trial. So 124 went to trial, of which 60% were successfully defended. And interestingly, when you look at the data, of those, most of the successful defences were in respect of breach of duty and causation. There were a small number that were successful on quantum, in other words, where the NHSLA had got their Part 36 offer right. So they don't seem to have fought that many cases where they were successful on the quantum basis. And I think most of us who do the work recognise that they will take a certain number of certain types of cases to trial, and they have a pretty good success rate, and I think that also reflects our experience. So, because I want to dovetail in with our two experts, orthopedic claims, we've been looking in more detail at the shoulder cases and the other lower limb cases in particular, and spinal cases. High rate of claims in orthopedics is probably going to be due to the fact that, firstly, generally non-fatal outcomes. Cardiologists, those cases, often it's pretty fatal. Obstetric, it's either very severe or fatal, but certainly with orthopedics, by and large, these are not conditions that people die from. They're conditions which people have to live with if they don't go well for many, many years. They tend also, and we've seen that in a lot of the examples that our two experts have dealt with, to affect those of working age. So it disrupts employment, normal family life. It has big consequences, not just for that individual, but also for all the other people who depend on them, their spouses, their children, other relatives, etc., etc. So that's why even a relatively minor injury, but that goes badly wrong because of failed surgery, then has wide ramifications, and you'll all be aware of that. Large number of procedures performed. This is where I just want to involve you in some of the statistics. I looked up the 13th annual report of the National Joint Registry, which deals with all joint replacement surgery. In the last 12 years, up to December 2015, how many total joint replacement surgeries do you think were carried out in total over 12 years? Any guesses? Peter?
300,000.
Okay. Anyone else want to go? Give me a number. Come on. What do you think? 12 years worth? 1 million. It was actually over 2 million. In that period, there were 800,000 hip replacement operations carried out. That was 40% of the total. And bearing out what Mr. Pearse has just said, revision operations, which of course we were always used to see in those medical reports, oh yes, going to need a revision in 10 years. Total number of revision operations in the period, 4.3%, only 89,000 revisions out of 800,000 primary hip replacements. So most people only have one. Knee replacements. What do you think? More or less than hips? Okay. Fewer, one should say, of course. Answer, although they have come more recently, so in fact there are more knees being done now than 12 years ago, number of knees done is now in excess of the total number of hips done. 875,000 knee replacement operations, 42.5% of the total. Of those, 2.6% are revisions. So again, we're not seeing revision operations being done in the numbers that you would expect from the medical evidence that we were given. Another interesting fact that comes out of that National Joint Registry survey, which bears out the statistics from the NHSLA, is that operations done, 60% hip replacements were on women and 50% of knee replacements were on women. Interestingly, that there seems to be a higher number of operations carried out on women. The median age for the first primary operation, 69 in the case of hips, 70 in the case of knees. So you can see broad parity over the sort of people who are having joint replacement and the ages at which they're having them. Shoulder replacement, much more recent, more difficult, not as common. Shoulder replacement also affected by the fact there are quite a lot of other treatments available, but only 8.4% of the total, 17,000 in all carried out. Statistics very much the same, 70%, over 70% of shoulder replacements in women, median age 73. So a very similar sort of demographic across those, but big, big numbers. And I think one of the things that that shows is that when you actually then look at the complication rates, they're very low as well. It's a good operation, and I'll come back to that because it's actually quite important when we come to look at consenting. And one of the major things I want to focus on is consenting post-Montgomery for routine orthopedic procedures, which are being done in their tens and hundreds of thousands. And just think about the implications of having a much more complicated consenting process. So, big issue we all know as far as litigation is concerned, patient expectation, and particularly in relation to joint surgery. The expectation is I'm going to be just as I was before I had my pain, my arthritis, whatever it was. It's not going to be as good an outcome. Pretty good, but not as good as it was before you had the replacement. And then obviously high rate of claims, pressure on the system and staff, increased by the number of serious road traffic accidents, which obviously take resources away from things like hip replacements. And because they are being seen as routine, then obviously that has implications. But as Michael pointed out to me, in fact, you've now got specialist centres who do so many of these that they've actually become much more competent. So what you have to balance is where is it being done? Obviously, an operation that's carried out somewhere that doesn't do a lot is going to have a higher complication rate than somewhere that's become very, very specialist. And increasingly, there are these big centres that just effectively churn the handle, and they're churning out operations, but to a very high standard. Okay, so types of orthopedic claims, a lot of this has already been covered in the material we've been looking at, so I'll race through this. Misdiagnosis or late diagnosis, we've heard about that. These are all pre-operative things. Poor history taking, poor examination. Those have been emphasised by our medical experts, all things that need to be done properly. Failure to make relevant investigations, so taking the correct x-rays, making sure you've got both side and face-on views, because otherwise you're going to miss something if you only look at it in one dimension. Missed fractures, including on x-rays. We've heard about follow-up not being in place when it should be. Then delayed diagnosis, we've probably all seen cases of this. I've certainly got a few on the go. Delayed diagnosis of conditional deformity of the hip, DDH. These are clicky hips where they're not picked up at early examination when they should have been, and other developmental conditions. Referred pain, we've heard about that. Someone's complaining of knee pain. It's actually not the knee that's the problem, it's the hip, and it's failing to think that it could be the hip when actually you've got someone who's complaining of primary knee pain. Failure to diagnose secondary nerve damage, that's already been dealt with by our medical experts. Failure to diagnose secondary circulatory impairment, compartment syndrome. And then the other one, which hasn't been dealt with, but which is quite, or not that uncommon, that's probably the right way to put it, CPRS occurring, chronic regional pain, sorry, CRPS, spelling mistake there, chronic regional pain syndrome, developing when the patient is in plaster, recovering from a straightforward fracture. You don't know when it's going to strike, you've got to be alert in your follow-up, and it comes back to the supervision after your primary assessment. Make sure that the patient is in reasonable comfort in their plaster, because it could be an indication that they're developing CRPS, and it's very difficult to treat if it becomes established. Then the key bit that I just want to focus on from a legal perspective, which touches a lot of this, is this issue about consent for surgery, consent for treatment. And the important point is that the complete spanner that's gone into the works in terms of the medical approach to it, which is post-Montgomery, which of course makes the consenting process a legal matter and not just a medical matter. Have all the relevant options been explained? Now, you can see immediately when you're thinking about Montgomery and its consent, you're talking to someone about mode of delivery, you can see why it's necessary to go through the options, because they're pretty limited. That baby can only come out in a small number of ways. But as you've actually seen from what we've heard from our medical experts, in respect of orthopedic injuries, there are a number of different ways of approaching the same problem. And if you've got to go through and explain all the relevant options, particularly in the context of this big data which has been talked about on a number of occasions, this consenting process becomes an absolute nightmare for any clinician, as well as for the patient, who it's arguable is being given far too much information. So, and not only do the options have to be explained, but there has to be an explanation of the potential outcomes. What are the risks? What are the percentages of those risks? And you can see that immediately it's difficult enough for us to persuade our experts to set out what the relevant options are and what the potential outcomes could be in their expert reports. And we're expecting them on the ward with patients to go through that exercise. I mean, it's great from a legal point of view, because you point to Montgomery and you can say, well, this wasn't, these things were not done. And the Supreme Court has said they've got to be done. But in most cases, this exercise is going to be very difficult for the surgeons to perform. And we'll have a bit of, I suspect, some questions about this right at the end. So, final one, types of orthopedic claims. Here we are, intra and post-operatively. I'm going to race through these. Nerve damage, circulatory impairment, we've heard about that, compartment syndrome, poor operative technique. I'd just add in there, I've had a few cases about incorrect use of jigs and things of that nature, which are designed to avoid the problems with implant surgery, but sometimes if they're not used properly, you get repeated errors which are made. And also some surgeons have tried to invent modifications which have been their own personal modifications to jigs and equipment. So you've got the X-tray, for example, which is a particular type of thing that's used, and of course it's not been tried and tested, there's not data to support it, and you can run into all kinds of problems around that. Inadequate or absent internal fixation of fractures, infection, we've talked a lot about that, DVT-PE. I'm not going to go through these because they've been beautifully explained already by our experts. So let's turn to the bit that I do want to talk about and just look at this in some detail. The consenting process. You're all familiar with Montgomery, or should be, but I recommend that it's always worth rereading. But let's just look at where we came from. Pearse and United Bristol Healthcare, Lord Wolfe saying, informed consent in respect of any specific risk of treatment means it's the responsibility of the doctor to inform the patient of that significant risk. So note the words significant risk if information is needed so the patient can determine for him or herself as to what course he or she should adopt. That was quite a good workable test because it's about significant risk. It meant you didn't have to cover quite a lot. Chester, I feel aggrieved about Chester because I was in Gregg and Scott and we lost Gregg and Scott, I think, because the House of Lords allowed the appeal in Chester. But anyway, I'm going to pass over that. But Lord Steyn said no place for paternalism in the formulation of modern legal rules. What was said was a patient has a prima facie right to be informed by a surgeon of a small but well-established risk of serious injury as a result of surgery. So we can see it's moved from significant risk to small but well-established. So we've got this beginning of the movement away from it just being only the significant risks. 1998, the GMC guidelines on consent required that patients must be given sufficient information in a way that they can understand to enable them to exercise their right to make informed decisions about their care. Changed 10 years later in the 2008 guidelines to consent patients and doctors making decisions together. And it's about joint decision making. The doctor and patient make an assessment of the patient's condition. These are the words from the guidelines, taking into account the patient's medical history, views, experience and knowledge. They both make an assessment of the patient's condition. The doctor uses his/her specialist knowledge, experience, clinical judgment, and the patient's views and understanding of their condition to identify which investigations or treatments are likely to result in overall benefit for the patient. So how can the patient's views and understanding about the condition be informed unless they have the information? So, which is why then the requirement, doctor explains the options to the patient, setting out the potential benefits, risks, burdens, side effects of each option, including the option to have no treatment. The patient then weighs up the potential benefits, risks and burdens of the various options, as well as any non-clinical issues that are relevant to them and decide whether to accept them, and if so, which one. It's about patient choice. This is not about doctors. Doctors can still make recommendations, but fundamentally this is a charter about patient choice, and it's also that the patient has the right to accept or refuse an option for a reason that may seem irrational to the doctor or for no reason at all. It's the patient is now the dominant party in that relationship in terms of the actual decisions. And that is obviously something which is an aspiration, and certainly at the time that those guidelines came in, if any of you got cases from 2008, was not the norm in terms of practice. In fact, quite the contrary, as we can see from Montgomery itself and what was done in Montgomery, where decisions were made which were not on that basis. We then get, this is an important case often overlooked, and it's one that I think all of us need to be very aware of, which is Birch and the University College Hospitals NHS Foundation Trust. Because this was a case where there were two means of carrying out an assessment, one of which was invasive, one of which was not. In fact, the neurosurgical department at Queen's Square did not do the non-invasive form of assessment. They only did the form that actually carried some small risk to the patient. But because they didn't have the non-invasive means of assessment within Queen's Square, the National Centre of Excellence, they didn't offer it to their patients. And in this case, she wasn't offered the less risky alternative or told that it existed, and the judge found Queen Square were liable because there was an adverse consequence, the 1% risk materialized, and Justice Cranston said in that case, the duty to inform a patient of the significant risk will not be discharged unless she is made aware that fewer or no risks are associated with another procedure. In other words, unless the patient is informed of the comparative risks of different procedures, she will not be in a position to give her fully informed consent to one procedure rather than another. That's massive as far as orthopedic surgery is concerned, when we've got budgets, when we've got healthcare managers saying you should be doing this procedure, should be doing that procedure. Okay, big data is helping to clarify some of these decision making, but actually fundamentally it still rests very much in the hands of the patient to make the choice as far as consent is concerned. Surgeon is quite entitled to say, these are the options, these are the possible outcomes. Your health service will only fund options 1, 2 and 6. But the fact is it doesn't let the doctor off the hook in terms of what has to be explained. So then we come to Montgomery, which then encapsulated all of this, including the GMC 2008 guidelines, where Supreme Court says in clear terms an adult person of sound mind is entitled to decide which, if any, of the available forms of treatment to undergo. Her consent must be obtained before treatment interfering with her bodily integrity is undertaken. The doctor is under a duty to take reasonable care to ensure the patient is aware of any material risks involved in any recommended treatment and of any reasonable alternative or variant treatments. And that means not only in this hospital, not only within this area, but which are proper variants. The test of materiality is whether in the circumstances of the particular case, a reasonable person in the patient's position, not the trust, in the patient's position, would be likely to attach significance to the risk, or the doctor is or should reasonably be aware that the particular patient would be likely to attach significance to it. And this is an objective test. It's not subjective. It's not subject to the Bolam test. This is a legal obligation, and it applies retrospectively. I mean, this is huge for the medical profession, and I'll be very interested to know how our doctors feel about this burden being placed upon them in their busy clinics when they've got patients who basically just want to know, doctor, what should I have done? That's what they want to know, is how can you fix me? So the consenting process in practice, what needs to be addressed? Fairly straightforward, although draconian. Options for treatment. Issues to be resolved in other cases. How far must actually be gone in terms of explaining all the options? Other treatments that may not be available at that hospital from that clinician but may be available elsewhere. Does this require doctors to actually be aware of treatments that might be available in the private sector, for example, which they aren't offered generally on the NHS? Proper advice as to outcomes to ensure management of expectations. Proper advice as to post-operative risks to enable the patient to be aware of adverse signs and symptoms. It's all part of the consenting process. The options in particular of conservative treatment or no treatment. Now, it should be, Andy, if we can just get up my other document, please. Just bear with me a moment. You have in your handouts a copy of the recently released NICE guidelines for low back pain and sciatica in over 16s. And this came out in December of 2016, so only recently released. If we can go back just to the front page, just so that the people online can see it, Andy, just page 1, please. And I think the message that we got from both of our doctors is that the world of what is being recommended for people is being transformed by these controlled studies. And we've seen, Michael made, in particular, Kurer made particular reference to this proper study, where the doctors have got to be extremely careful to make sure that they give appropriate advice, looking at Montgomery, that these are the findings of a random controlled study. We've also got it, as we heard from Michael Pearse, in relation to arthroscopy now. You know, it's not simply, yes, we'll have an arthroscopy, see what's going on. Has to be real caution exercised and proper consent given around the study done in relation to arthroscopy. I'm going to talk about spines in a moment, but we also heard mention of Colles fractures. This data has been coming out in terms of the management of Colles fractures, and also in respect of Achilles tendon ruptures, where they are less than 10 millimeters. So I just want very briefly to point you in the direction, because there are so many back cases of this guideline, because one of the things that has fundamentally changed, which is part of this guideline, is that whereas previously we will all be aware of fusion being a major treatment for low back pain, it is now the recommendation of NICE that save in specific circumstances as a treatment for back pain, you do not offer fusion. Page 10 of the guideline. If we just look through to page 10, please, Andy. So some of these things are really quite interesting. I'm going to ask you to look at some of the lesser things that are no longer appropriate. But on this one, surgical interventions, I'm just looking at the moment here. So surgery and prognostic factors do not allow a person's BMI, smoking status or psychological distress to influence the decision to refer them for a surgical opinion for sciatica. And I can see Michael Kurer's eyes are opening extremely wide having read that. And I imagine most of us are a bit concerned at seeing that written, because failed back syndrome, there's an awful lot of data out there that tells you that those are key indicators as to whether you're going to get a failed back surgery. But you're not allowed to let those matters influence your decision for surgery. Spinal decompression. Consider spinal decompression, that's as it was when the function and radiological findings are consistent with sciatic symptoms. But the big one is spinal fusion. Do not offer spinal fusion for people with low back pain unless as part of a randomized controlled trial. That is new, it's just come out. They give the explanation for it later on in the handout on page 17, at section 5. And they say, why have they made this recommendation? And they say an increasing number of procedures have been proposed for surgically managing low back pain. One of these procedures is surgical fixation with internal metalwork applied from the back, front, side, or any combination of the three routes. I suspect all of us have seen post-surgical problem cases, particularly where it's ill-advised surgery. But it seems that the primary driver of this from NICE is the cost of these operations has risen. And now that minimally invasive approaches are used, more of these operations are done with uncertain benefit. As well as the cost, surgery can lead to complications. Some studies report around a 20% complication rate, which is why they come to us. Overall, the studies do not show a clear advantage of fusion, but do show some modest benefit for some elements of pain, function, and quality of life. So they're not saying surgery doesn't give benefit, but they say, and they go on to say, the studies also show healthcare use was lower. They say it's not known what treatment should be tried before surgery is considered. I mean, this is, anyway. The evidence from the studies was weak because of low numbers of patients, large crossover and in-case selection bias. This means there is a need for a large multi-center randomized trial with sufficient power to answer these important questions. So in other words, the advice from NICE is you don't do it unless it's part of this randomized trial process. All those old practices are to be swept away. That's NICE's recommendation. Very interesting that that is the conclusion that's come out in this guideline. And I think it will come as a huge surprise to many of those who are engaged in spinal work. One of the other things that I picked up on going through this, which I think is interesting again from, and I recommend to read to it. If you've got a low back pain case, really you need to read this now, because this is the current thinking. For example, it says don't offer acupuncture for back pain with sciatica. don't offer traction, don't offer belts or corsets, don't offer foot orthotics, don't offer rocker sole shoes, do consider psychological therapies, but only in combination with other treatments, although they seem to have excluded most of the other treatments, so I'm not quite sure how that works. The big one that I will surprise most of you, as it surprised me, and again they've given a similar justification to the surgery one, is on page 9 under spinal injections. Do not offer spinal injections for managing low back pain. Although what I thought was quite interesting is that when you go down to 1.33 at the bottom of the page, it says only perform radio frequency denervation in people with chronic low back pain after a positive response to a diagnostic medial branch block. So you can do your diagnostic medial branch block, but you can't otherwise give injections. I'm sure there'll be some interesting debate about this, these guidelines now they've come out, but I just thought I'd draw it to your attention because I'm not sure that everyone's familiar with it. I'm familiar with quite how striking some of the conclusions are. I haven't spoken for the full hour, but we've had an awful lot of information. I suspect a lot of the ground I was going to cover has been adequately covered by others, and I think the other point is it probably is going to be helpful to have some input from the doctors in relation to this issue around Montgomery and consenting and their view from the medical perspective. I think Mike Pearse has gone, but yeah, I think he has. But anyway, I'd be very interested to hear what Michael has to say on that before we then open it up to the floor for questions more generally. So that's all I'd wish to say by way of my primary thoughts to you, but I'm here to answer any questions that you may have. Okay. Thank you very much.
Michael, do you want to respond?
I'll say very briefly.
Let's switch.
1, 2, 3. Yeah. I'd say very quickly, I think as you can tell, we are moving just into more of an era where we're basically throwing it over to the patient. He's driving. He's been given the chance to drive his treatment. You're saying you can do this, you can do this, you can do this. Like going to a travel agent, you go on this holiday, you'll go on this holiday. You can have this operation or this holiday. If you go on that, you'll get this, and with this, you'll get that, and so on and forth. And it's much more of an emphasis throwing it over to the patient, and in particular, no treatment. And I mentioned during my presentation about rotator cuff repair. I had a patient in today who'd been at the gymnasium. He pulled his muscle, and it hurts like he's ruptured his rotator cuff. And we had a long discussion about having no treatment because actually they do quite well, and having treatment, but he's being mindful of him. He likes going to the gym. He's 69. He likes to go to the gym. But the whole dynamic is changing to I need you to go away and think about it. Think about this option. Think about this option. Think about this option. And then also the dramatic thing is something like NICE guidelines saying stop doing epidural injections. I mean, I'd be very relieved to hear it. There's no point in me giving you an epidural. I'm not allowed to, and they don't work anyway, you know. So, but we're going to be controlled more correctly. I mean, no disc replacement. You've seen people having disc replacements. I mean, you know.
Thank you. Right. Who else would like to contribute? Peter Ellis. Can I hand you this so that wearing his hat as Dr. Peter Ellis. Thank you, sir.
Michael, I had a question for you. Based upon the guidelines that Julian has very helpfully shared with us this evening, a vast amount of private medical practice, both alternative and conventional in London, might disappear if those guidelines were followed religiously. Does the mere fact that NICE proffers guidance on therapies such as acupuncture, TENS, or spinal fusion, does that mean that when you're offering those treatments, they are not reasonable alternative treatments within the Montgomery test? In other words, is this a cost-driven agenda which still allows Montgomery compliant offering of such alternative treatments as being reasonable?
I mean, it's basically, if the NICE guidelines, you're duty bound to tell people what the NICE guidance is. And the NICE guidance says acupuncture is of no benefit, or is not indicated. You're duty bound to tell them. And if they say, look, that's all very well, but my friend this and my friend that, and I'm prepared to pay for acupuncture, that's fine. And you say, well, there's a risk of hepatitis or not, whatever. But the guidance is the guidance. It is only guidance, but nevertheless, it is powerful. And it's equally justified. It's not justified to offer a fusion. And if you do offer a fusion, you don't warn them that this is not, there's not enough science to back it up and it all goes wrong, then you've put yourself at significant risk.
So if it's in here, then it's not a reasonable alternative.
It's a reasonable alternative provided the patient knows that essentially it's not really approved of, and it's their choice. They can weigh up the size of the evidence, but they have to know that NICE have said this is not up, this is not.
Right, thank you for that. Anyone else? Hands up there? Come on, chaps, this is cutting edge. We've got to debate this. It really is. Hot off the press from himself. Ah, dear drinkers. So microphone back, please. Should be on, I think.
This is aimed again at Mike. Am I right in thinking that NICE guidelines are not entirely compiled by clinicians?
Well, they're big use.
Come to the microphone. Yeah. You are right, but it's a sort of, it's a big group and clinicians form a very big part of it.
So if you as the individual are advising a patient and you say this is a NICE guideline and he says, but what is your opinion?
Yeah.
Do you think, for example,
Yeah.
because my podiatrist tells me this, in fact my podiatric surgeon tells me that I can have a conservative management if I use an orthotic. Do you as a clinician believe that you can talk to me about that and advise it, or do you feel you are gagged?
No,
by
I don't think
guidance?
you're gagged. You're not gagged, but equally you can't fly in the face of the guidelines either. You can't go and do a lumbar fusion without informing the patient that it's not really approved of by the.
Even if your view is, if you're asked what would you do?
Yeah.
Yeah,
No, you
and
can express your view on that basis. You can say, well, the NICE guidelines suggest this. There's only what basically it's saying is science is suggesting there's only a minority of people who will be of benefit and there'll be potential for complications. Nevertheless, in your particular case, in my view, you would nevertheless be an excellent candidate for these reasons, and therefore I recommend it. But it's all got to be open, because if it all goes wrong, you're going to have to justify why you've made the
But if
recommendation.
you feel that you are bone and belitho in the right position to say, well, I may be in a minority, but I'm responsible, and my view is that for you, customized to you, the patient, X is good, although the guidelines say
I think that would
X
be a fair
is
call,
not.
but you are on the back foot to justify it. You as the surgeon flying in the face of that are going to have to come up with lots of reasons why you made that recommendation in the face of this, and that the patient knew you were doing and going out on a limb.
But I would suggest that the wording itself in the NICE justification gives the indication that it is primarily cost-based. And it's not saying you're not offering it because it may not be of benefit. In fact, that bit I read out indicates that actually in certain patients it may be of benefit. So therefore, it seems to me from the individual clinician's point of view applying Montgomery, that full advice still has to be given if it is potentially of benefit. The issue is going to be around whether or not it's going to be funded, and I think this is very much directed at what the NHS is going to be prepared to fund for specific conditions. And the interesting issue from a legal point of view is, will you be able to sue if the trust refuses you the surgery that on a clinical basis the doctor assessed would actually have been beneficial? And I think that's going to be the interesting question, because that is then the refusal of reasonable treatment by the trust. And I think that runs into some really interesting questions for us as lawyers.
Well, I agree with that also. The time taken in a consultation to then have the overlay of going to the justification as to why NICE make a recommendation which runs contrary to your clinical intuition and instincts. Yeah. It's going to be incredibly time consuming. And then they're going to miss all their guidelines and their deadlines on treatment.
But I suspect what's actually going to happen is it will simplify the consenting process, because what will happen is the registrar, whoever is dealing with the clinic, will simply say, well, the guidelines say no, so the answer to surgery is no. So it simplifies that process, but what it means is that then when the person gets no relief and actually deteriorates, they then go trotting off to their lawyer to say, well, I was refused surgery on an improper basis. So I think it's going to be very interesting to see how it works out in terms of that interplay between the surgeon's duty, which of course, as I emphasise under Montgomery, is a legal duty. It's not one which is BOLAM defensible. So the surgeon can't turn around and point to NICE and say, oh, well, I relied on the NICE guidelines.
Thank you for that. Now, I'm sorry that the barristers have monopolised this. Are there any solicitors who would like to contribute? I have no hands. I have no hands. In which case, we're going to continue this debate in the bar outside and close tonight with our thanks to all three speakers.